Good evening, class. Okay, so
Good
I
evening.
hope you
I'm
guys have
sorry.
good evening. It's all right, Daniel. Thank you. Oh, you guys have an amazing day today. So I don't know how's the weather over there. Not even worry. Here it's hot, but there probably is very cold. So again, just dealing with the temperature, whether it's cold or hot. Okay, so let's move on with this chapter. We're going to continue with patient positioning. Remember, we talk about the standing position, the sitting position, the um, prone position, the supine position, the semi-Fowler's position, and Fowler's position. Now we're going to move to the lithotomy position. Now, this position, once again, it is a very common question for exam. So remember, I highlighted in yellow. So everything that is highlight usually comes in exam. So it's a very, very important thing that you kind of, pay attention to this information. So let's talk about this particular position. What is it for? Because the most important thing is, why are we placing the patients in this particular position? So you can call it either way, because that's how usually the questions on the exam are stated. It is used for pelvic examination, mostly for females, or the pap smear test. So that's basically what it is. So this is position when we are going to place the patient, when you're going to do the examination and part of the internal genitalia. So that's basically what it is. So you are, females, most of you. So because in my class, so for that reason, this is a test that you should probably are familiar with. You probably didn't know what was the name of the position in which were placed whenever they're going to perform this procedure. Remember, it's called the lithotomy position. Now, how is this position? How we are going to assume this position? How we are going to tell the patient so most of the US, oh hi, Miss Smith. The medical doctor is going to perform or is going to do whatever it is you choose words, but you have to be professional. So the medical provider is going to evaluate you, or is going to do a pap smear, or is going to do a pelvic examination. Have you ever had these exams before? Don't assume that because it is a female and it's in its 18, 20s, 30s, 40s, 60s, 80s, this patient already is familiar with. You got to make sure whether the patient is familiar, because that's going to help you to explain in a very, very simple way. See, the patient have to have this position before they know already, or this procedure before they know how to adapt themselves to this position. Now, I'm telling you this because I did these evaluations on my patients, and I have patients that they were 40s, they were 50s, they were 60s. They never had a pap smear in their lives. That was the first time. So I don't want to assume that this patient Oh, it's 40, 50, 60. Oh, wow, this patient has gone through all these tests every single year. No, it's not true. So some of the patients never have never had these procedures. So for that reason, you as a medical assistant, when you try to explain them what exactly the medical provider is going to be doing, you're going to tell them how to adopt this position. So ask them always, whether it's male or female, for other procedures, of course, you're going to ask them, have you ever had this procedure, Mr. Smith? Have you ever had an electrocardiogram? Have you ever been, examine how your heart works? Or have you ever had this vaginal exam, if you want to call it that way, or a pelvic exam? I don't know what words you're going to use to make sure that your patients are going to understand. But a pelvic examination usually none of them use the long term Papa Nicolau. So if you want to use that term, that is okay if they are familiar with. But don't assume that they know the procedure. So then you said, oh, well, the doctor is going to be the procedure. Just change yourself and, wait for the doctor. That doesn't work. That's not how you explain to patients how a procedure is going to be done, or what is the position that they need to assume when they're going to see the doctor. So the first thing that you're going to do is you're going to ask the patients to lay down on the bed facing up. The first thing. Then you're going to ask the patient to slide down where the bottom or the buttocks are going to meet the edge of the table. So that's basically what it is. And then you're gonna pull out the stirrups. These are these kind of two arms where the patient is going to put their feet on it. So that's basically what you're gonna do. Now, if it is the first time, you have to walk the patient through without removing their clothes. Do the position before you remove your clothes, because it's a very uncomfortable position and you are not the medical doctor. For that reason, do not expose the patients. Then ask the patient to remove their clothes from waist down. You give them a gown, you give them a drape. That is basically how it's done. Now, again, just the moment that the medical doctor walks into the room, then you're gonna tell the patient, Mrs. Smith, please, just place yourself in the position that, we went through already, or that I explained you, that I walk you through. And that's exactly what you're gonna do. Stay by the side of the table, because the patient can fall. Patient can easily kind of slide to the side if they kind of scoop down too fast. So be there on the lookout when the patient assumes the position. Remember, it's not recommended to place the patient in that position until the doctor arrives to the exam room, because this is a very uncomfortable position. Even though if you have done this few or many times, still it is an uncomfortable position for the females. And besides, you're gonna get tired if you place them before the medical doctor arrives into the exam room. You have to wait for the medical provider. So that's basically what it is. So wait until the doctor enters. When the doctor enters, now it's a different issue, because the doctor is going to wash their hands, they're going to put their gloves, they're going to get close to the patient, they're going to greet the patient, and blah, 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 blah. So this is the time that you're going to use to position the patient. Remember, this is called the lithotomy position. And what is the lithotomy position? Used in which procedures? Pap smear or a pelvic examination. So that's how it's done. So let's go back here. Never mind. This is the picture. Remember? Once again, see the patient is laying down on her back, but then the buttocks is right here at the edge of the table. Here, there is no need to pull down the extension of the table. You don't do that because you don't need it. Instead, you're gonna pull down, because here you're gonna pull out the stirrups, see, where the patient is going to be placing their feet in both sides. So basically, that's what you're gonna do. So be careful with this. Now, the patient is gonna have a drape or a blanket. Remember, covering completely. So when the medical doctor comes in, he or she will remove or place the drape folded over the patient's abdomen. They do not remove it. We just fold it on the patient's abdomen and we start doing the procedure in this area. Medical doctor has to have a little sitting stool right here, because the medical doctor is going to be sitting and you are going to be right here assisting the patient from this side. So that's how it works. So once again, you have to be there next or besides the table, making sure that your patients are not going to fall off the table. Be careful. Once again, these positions are very, very uncomfortable. So the sooner that the medical provider do the procedure, the sooner that you can assist the patient to, you know, to remove themselves from this position. So that's basically what it is. So I didn't mention it before in prior positions, but you are going to assist them, assuming the position that they need to be in for the procedure. But then when they finish, you gotta be there also, making sure that the patient is not gonna fall off from the bed. Remember, you're gonna be just standing by the side and offer your assistance. Particularly in this position, the patient might fall off. Another thing that the medical assistant should do here when you are working or assisting the medical doctor, you're gonna give this patient some paper towels after the medical doctor is done. Why? Because they are going to wipe themselves. Because remember, in this part of the genitalia, the medical provider is going to place some lubricant and some secretions are going to come out, some vaginal secretions. So for that reason, you're going to provide the patient with a towel and you're going to remove yourself from there. You're going to look the other side. And when the medical doctor is doing the procedure, you do not stick your head around here trying to see what is it that the medical doctor is doing. You're going to be standing next to the patient, but not looking at what the patient is doing. You're going to be checking the patient, comforting the patient, asking the patient if they feel okay. So that's basically what you have to do, not checking out what the medical doctor is doing. Because, that's our job as a medical assistant. Believe it or not, as a medical assistant, I assist a gynecologist doing this procedure. As a male, she called me and she said, Alberto, you're going to assist me doing this. I was like, wait a minute. I'm refusing. I'm not doing that. This is a female. She's gonna feel uncomfortable then I'm gonna be doing the test. So I told the medical doctor, I said, wouldn't you rather have a female assistant? I said, you're a medical professional, so you're gonna do it with me. So every single time that she had this type of procedures, she asked me to assist her. So there is no way that I can refuse. But these are the things that I do. Besides the patient, checking the patient instead of seeing what the medical doctor or is doing. So that's basically what it is. So make sure that you do the right thing. Any questions about the lithotomy position or the exam or the position for the test or the procedure, which is called the pap smear or a gynecological exam. So remember, a pelvic exam, whatever the case may be. So you gotta make sure that you explain the patient prior to the patient has this procedure. So once again, you're females, you should be a little more familiar with this, more sensitive with the patients. Do not make jokes about any of these situations in any of the positions. Don't tell us, yeah, I know, this is very uncomfortable position. I know this. No, don't make no comments. That is unnecessary. So just tell the patient, okay, so we're gonna sit right here. So please sit right here on the table. When the doctor comes in, then you can assume the position that I already work you through. Okay, so that's it. And when the patient and then the medical doctor comes, that's exactly you're gonna do. Said, okay, now you're gonna assume the position and you're gonna be right beside the bed, directing the patient to scoop a little more farther up to the edge of the table. Remember, you have to tell them. Of course, sometimes they are a little off inside, so the medical doctor is gonna tell them just scoop a little bit more farther, towards me, and they will kind of complete the procedure. But you're gonna make sure that the feet of the patient is steady on these stirrups, because other than that, it's gonna be very uncomfortable. Can you imagine the foot or the leg of the patient falling off from the stirrups while the medical doctor is doing a procedure? It will be very uncomfortable. So that's the reason why we wait until the medical doctor is ready in the exam room for us to place the patient in this position. Remember, this is a exam question, so make sure that you don't forget this. Any questions once again? Another thing, you should not be embarrassed. You should not be skeptical or any of the kind when you're going to assist the medical doctor. These are procedures needs to be done. If it is a male that the medical doctor is going to examine their anal canal, the testicles, the penis, normal. This is a job. And this is what medical assistants do. This is what doctors do. So if you were gonna assist them, we're gonna assist them in some procedures that sometimes you might be like, kind of, oh, wait a minute, I didn't know that this procedure was done. So don't show that you are kind of, surprised or anything like that, because the patients are looking at you. So no, pretend that you've seen this many times and don't look things in a different direction. Just do it in a professional way, because that's exactly what we're supposed to be doing. So that's how it works. And when you get off from the room and you clean everything, do not go to the waiting area or where your colleagues or your buddy start talking about what you just, you know, have seen, or what tell about the procedure, how the patient looks like, how was this and that. That is unprofessional. Remember, that's violating the patient's privacy and confidentiality. So be careful with any comments out of context when you leave these rooms. No, you do the exam, that's it, stays there. It is between you, the patient, and the medical doctor. You can get fired if you start spreading rumors about what you have seen during the procedure, because that's violation of the patient's privacy. Okay. Next position is called the Sims position. Now, Sims also is the position based on, the name of the doctor who invented this procedure or discovered this procedure. So that's basically what it is. This position is also known as lateral position. Now, no one is going to ask you that because it is a very common known as the Sims position. It's just that they call lateral because the patient actually is laying in one of the sides. You're going to see the image later on to see how it looks like this position. So how we are going to tell the patient how they are going to assume this position. Well, mostly, not all the time, mostly it's done for males to do the digital rectal exams to check for the prostate. Males after 50, make sure that you know. Remember that I told you, you need to be familiar with the patients. It's a male, it's a female, it's this age. Gonna do physical exam. Probably they're gonna do this. Probably they're gonna do that. If it is a male and this male is over 50s, the medical doctor is going to do during a physical exam a digital rectal exam, which is placing the doctor's finger right inside the patient's rectum. So that is basically what it is. Once again, this is not a reason, a motive to make jokes or to laugh about it or try to be kind of surprised about it. No, this is the medical field, and we call the things by their names. If it is the rectum, if it's the anal canal, if it is the penis, what is not acceptable is saying other words, using vulgar language to express the anatomy of the patients, because that changed the whole scenario. That's a different issue. That's being very unprofessional. So avoid making comments. Just keep your mouth shut. Believe me. If only if I was asked to pass something or get something, I might respond to the medical doctor. Sometimes I didn't even respond anything. I don't need to talk. I'm more engaged with the patient. Are you okay, Mr. or Mrs., whatever it is? So yeah, I'm fine. Okay. So you are, once again, paying attention what the doctor needs, not what the doctor is doing, what the doctor needs. So you can pass them, because we're going to have a little table right next to the bed. So the medical doctor is picking up stuff, but sometimes they might ask you to bring something else. So you have to be there, or to pick up specimens that have been collected. So you got to receive them and cover them and label them. So you're going to be learning exactly how all these work. So once again, do not laugh, do not look surprised, anything at all. If you have the chance to see any of, the parts of the anatomy of the patient, because remember, it will be, the violation of the privacy, and you're going to embarrass the patient. You don't want to do that. So what you're going to do is you're going to ask the patient to go on the exam table, and, they can, all of them, they can start by laying down on the patient's back. And then you tell them to turn onto the left side, because it's over the left side. Then you're going to ask them to stay in this position. Now you're going to ask them also to flex the right leg. Has to be flexed or bent, because we are going to expose the rectal area or the vaginal area. But for the vaginal area, usually it's not done in that position. We do the lithotomy position or other positions that we might see later on. Once again, it is very important for us to cover the patient, to drape the patient with a blanket. Remember, the gown is not enough, because the medical doctor is going to remove the gown. And some of the times, depends where the gown is open, you're going to expose some of the parts of the body of the patient. You don't want to do that. Not to mention the temperature inside the room. Remember that sometimes it's cold. So that's basically what it is. So let's look at the position. Here it is. So sometimes actually, we sleep like that. Nobody's going to be doing exams there. It's just done It is a comfortable position when you are in your bed, but here it's not so comfortable if you are in an exam room when they can do a procedure. So that's exactly where you're going to place the patient. Remember, this leg, the right leg, has to be flexed so we can expose this area right here, which is the anal canal and the rectum. Once again, this is a very, very common position to do a colonoscopy, a sigmoidoscopy. Whether it's a male or a female, remember through here, we're going to introduce and scope a tube with a camera that goes in, through the anal canal to the rectum, to the sigmoid, to the large intestine, the whole thing, to the ascending, descending. So we're going to evaluate. So it is a very common test as well. So if you work with a gastroenterologist, and these are the medical doctors that deals with colonoscopies, sigmoidoscopies, or even with hemorrhoids that can be checked this way as well. And is a comfortable position for the patient. First of all, because the patient is not seeing what's going on, and the medical doctor just focus themselves right here in this area. So remember, sometimes if we were not used to these particular exams, we tend kind of, be a little surprised or taking things like not seriously, doesn't look professional. So you have to pretend at least, that this is okay. That's the reason why you shouldn't be looking. Or what is the medical doctor doing? You should be right here in this position, close to the patient, right here, comforting the patient probably, distracting the patient, not talking to them, but right there. You can start sometimes, you can kind of give a little pat on the shoulder. Are you okay, Mr. or Mrs. Smith? They say, yeah, I'm fine. So comforting them, because sometimes they are very apprehensive. This is not a comfortable position, particularly for the test that they are performing. So make them feel like, everything is okay, everything is normal, because it is. But they don't feel like it. And sometimes if we're not used to, you don't feel like it. You might be thinking things, but don't say it. What do you think? We're not humans? Of course. When I have to place these patients to do all these procedures, because I did all these procedures on my patients. So guess what? You're not going to be kind of surprised. No, this is like, writing down on a notebook. This is every single task that we're going to do, get comfortable with, because that's how it works. Any questions about the SIMS position? Remember, most of the common exams that we do here is rectal exam. There is another position that they remove, that they replace for this one. Back in the days, still there are some old doctors, older than me, that are still working, not working as a doctor anymore, that they place the patient right here on the bed and they lean right here on the table like this. So the medical doctor can see the borax through this side. So the patient is standing right here over the table, just bent forward. That was very uncomfortable and kind of even more embarrassing. So they kind of not doing this anymore. Instead, they doing the SIMS position. So again, you might end up with a medical doctor that is going to be asking the patient to place themselves in this position to do the rectal exam. So, hey, Just go by the flow. That's it. That's how it's done. That's the medical doctor's preferences to do their test because that's how they learn. That's how they feel comfortable. So just go by the flow. Other than that, this is the most common position for that procedure. Remember, rectal examination for the exam. But if you have that the question has changed and now it says, okay, in which position are you going to be placing the patient to do a colonoscopy? Same position. That's it. Remember, colonoscopy, colon. Well, this is how we access the large intestine. Okay. Any questions? Okay, let's talk about these not so common positions. So this is the recumbent position or dorsal recumbent position. This position actually is not done anymore. It's the most uncomfortable position for males or patients. Very uncomfortable. So the dorsal, oh, listen, oh no, this is not the most, because this looks like, the lithotomy position. I'm sorry, my bad. That was not. So the patient is going to be placed on a supine position. The only difference with the supine position is that the patient is going to bend their legs by the knees. So that's basically what it is. So what is this position used for? Remember, this is similar to the lithotomy position. It's just that the patient is not placing the feet on the stirrups. They're just going to be placing the feet flat on the table, the exam table. So it is within the table. So what is this position used for, or was used for? Because these positions usually we don't do it. They are kind of a little uncomfortable for the medical procedure, for the medical doctor to do the procedure, because the patient is actually all the way inside the table. So it is very uncomfortable. We have to kind of lean forward, kind of try to reach in there. Instead, we do the lithotomy position. We're gonna protect the patient's privacy by covering the patient all the time. Every single time that the patient removes any part of the clothing, we have to give them a drape. Even though if it is just the upper part and it is a male. Remember, sometimes just for the purpose of, temperature wise, because sometimes says, oh, males don't have anything to hide, it's just the chest. Well, not everybody thinks the same. Are patients who do not like to be exposed. Males, they don't want to be exposed the chest, even though if it is the chest. Because sometimes they have some type of marks, some type of deformities in their chest, particularly when they have gynecomastia. So if you don't know what is gynecomastia is when the male's breast is very enlarged. That looks like they have breast, like females. So some of the patients feel embarrassed to show their chest because of that. So we have to be very, very sensitive. Remember, not everybody, acts or, you know, takes things lightly. No, they have their own, way of, presenting themselves. And there are some things that they don't want you to see, and then you want to cover. They are kind of forced to be exposed, so to speak. So be careful with that. So this is the position. Remember, it looks like the lithotomy position, but it's not, because the patient has their feet flat on the table, but the legs are separated. So the medical doctor can have access to the, genitalia. So that's basically what it is. But it's kind of very farther into the table. So the medical doctor has to kind of lean and try to reach back there. So having the patient right here with the buttocks right here in the lithotomy position and the legs in the stirrups are going to be a lot more the patient for the procedure, because you don't want kind of, harm the patient, the procedure, because you have to use sometimes some instruments, and when it's farther away, you might, kind of make the patient feel a little uncomfortable. So that's basically what it is. That's not different or anything else. This procedure, you're not gonna be asked about it. So that is this is the one that I was talking about before I started. The other one, the other position, the dorsal recumbent. This is the knee chest position. Once again, this is the most uncomfortable position of all the positions that we have covered. This position is no longer used. I've never placed my patients in this position, and I have not seen any of my colleagues placing the patients in this position because it's very uncomfortable. Instead, we're gonna do the seams position, because this is the position that we are going to use to expose the patient's anal canal of the rectum. But the way that the position is, with the patient is placed, it is very uncomfortable, and the patient gets tired. So that's basically what it is. So if you ever see this position that the patients, that the medical doctors wants to do a procedure and they want to place patients themselves in this position because they feel more comfortable doing the procedure, well, here you know what it is. But once again, do not laugh, do not make comments, do not do anything, nothing. You stay cool, calm, like nothing happens. Now, for this position, you have to assist the patient, because what the patient is going to do is the patient is going to go on a prone position. The patient is going to lay down, facing down, or laying on the patient's belly or abdominal region. Then you can assist them in elevating buttocks, and then part of the breast and the table. So that's basically what it is. Once again, a very uncomfortable position. You should not remove yourself from the side of the patient when you're doing this, because the patient can kind of fall either side. So you're going to be there. So this is the position. Remember, very uncomfortable. It's called the knee chest position. Remember, in the medical field, we have to be very professional. When I was teaching this class, my students in other schools, patients were laughing about this. Students were laughing and making comments, and you know how your mind just go everywhere. So you should avoid this in front of your patients. I know you, if you're there, you might be thinking things, and yeah, whatever you're thinking, that's normal. But in the process of assisting the medical providers with this position, if that's the case, you have to be very, very professional, believe me. Because other than that, the patient is going to be embarrassed, and you're not going to be performing correctly because you're going to be thinking something else instead of assisting the patient or assisting the medical doctor. So please, just make sure that, you are in a professional setting. I'm telling you this and been through a lot of stuff. and I know exactly what I'm talking about, and I know that you are understanding what I'm trying to tell you. So be careful with these positions, making comments or any of the kind. So please, once again, keep your mouth shut. Don't even flinch. Any questions about any of these patients positioning for these particular exams? Remember, this exam is to check the patient's rectum most of the time, but now this is the area the medical doctor is going to be standing here and looking right here with or doing whatever procedure they need to be doing, and that is it. Now, once again, patient is going to be draped from the moment that is going to be placed in this position. Then the medical doctor is going to roll this drape all the way down. They're going to roll it right here, expose this area, and when it's done, place the drape back on. So that's how everything works. And you got to be there assisting the patient. Remember, you have to be here by the side, making sure that the patient do not fall to any of the ends of the table because, well, patient can get injured, okay? So that's basically what it is. Any questions about any of those positions that I told you that they are highlighted? You need to know it. So when you about to take the national exam, make sure that you review this material so you can get all your questions right for that test. Things to remember after you assist the patients assist the medical doctors and the patients during these procedures and this positioning is the responsibility that you have for the safety and the comfort of your patients. Remember, safety, you don't want them to fall. So you want to tell them exactly how to do the position, when to do the position, not to keep them too long there in that position. Remember, wait until the medical doctor is there. Their clothes should have been removed already. They have a gown, they have a drape or a blanket. They are covered. And when the medical doctor comes in, then you tell the patient to assume the position. Remember, that's how it works. Keep patients free from harm. Remember, we are keeping them with comfort, not harming them. You don't want your patients to fall off. Remember, depending on the age of the patient, the condition of the patient, certain positions might be changed. Even though if it is for the procedure, but they will look other means to do the procedure, placing the patient in a position that is comfortable for the patient. Now, look at what it says right here, because this is what is going to keep the patients free from harm. Never leave unsteady older adult patients sitting alone on an exam table. Well, I will not leave anyone because as soon as the patient assumes the position, you're going to be there assisting the medical doctor. So you're going to be there all the time, making sure, checking, monitoring the patient. You're not monitoring the doctor. You're monitoring the patient. Because the doctor is concentrated doing whatever they're doing during the procedure. But who is monitoring the patient? You. So that's basically what you need to do. So be careful because that can have some serious consequences. Also with children is the same. If you work for a pediatrician and you have to take care of a child, never leave your child there because your child moves and falls off from that table, and that table is pretty high. So if someone falls off from that table, the least that you're gonna do is gonna break something. I've seen many situations, very serious situation happening. The child fell off from the table, is dead. An elderly fell off from the table, dead. Others, they broke their arms, they broke their shoulders, they broke their hips because you left them unattended. Oh, place yourself right there, and you turn around and start doing something else. No, that's why it is recommended that you place the patients in this position when you are ready to do the procedure or your medical doctor is ready to do the procedure, not before. Once again, we are going to go over the position just to make sure that the patient knows what to do when the medical doctor arrives to do the procedure. So that's how it works. Okay, so we kind of changing a little bit, moving now to the actual examination. So what is it that the medical doctor is going to do during that particular exam? Remember, you're going to place the patient on these positions after you explain the procedure, ask them to remove certain parts of the clothes, whatever is needed. You give them a gown. They have a drape for privacy and comfort. Remember, temperature wise. And now the medical doctor is going to come to do certain evaluations. So you got to learn these particular evaluations that the medical doctor is going to do. Not because you're going to do it, but because you will be asked on your national exam. The medical doctor is going to inspect the patient. So the medical doctor is going to observe the patient. That's basically what it is. We're going to check the patient from head to toe. Then if the patient says, I have a rash right here, I have a swelling right here, I have some bulging right here, I have this bruise right here, or whatever the case may be, we're going to focus right in that particular area. We just observing. That's what it's called inspection. When you inspect, you just observe. You just look at that particular part of the entire body or part of the body. That will be the visually examination of the patient. So that's basically what we do. So inspection. So every single time that the patient comes into our room, the medical doctor's exam room, we inspect the patients. Oh, I have pain in this arm, in my elbow, in my ankles, in my knee, and whatever part it is. Okay, so we want to uncover that area and we're gonna see. But remember, we're not gonna touch. We're just going to observe to see what we're seeing. What is it outside? There is any bruises? There is any laceration? There is any bulging? There is any deformity? Do the patient have a rash? What is it? Something is going on. Because remember, we complain about something. So that is called inspection. So here it is. Now, this picture is not an inspection. This person, which we assume is the doctor, is touching the patient. No, you're not touching. During inspection, during observation, you do not touch the patient because it's going to be another procedure, physical exam, which is touching. Now it's palpating. Now it's feeling the area. So this person should be only observing, just looking, just like the patient is looking at the patient, at the medical provider should be doing the same. So these are the questions for your exam. So when the doctor is inspecting the patient, what is the doctor doing? See, it's very simple, but sometimes we get confused. If I'm inspecting you, I'm observing you. I'm visually examining you. That's basically what it is. So that is an inspection. Remember, I'm going to inspect you without touching you. I'm just going to observe all around. Turn around. Let me see. Raise your arm. Left, right. Walk forward, backwards. Close your eyes. Look at the light. Open your mouth. But I'm not going to touch you. I'm just going to observe, particularly for deformities, for injuries. Because you told me, or your chief complaint, or the reason that you are here today is because of back pain. You have this particular condition. Now, I'm going to check that. I'm going to observe. Remember, this is observation. Number two, that will be touching, palpation. Remember, palpation means to touch, but to touch in a professional way. Your medical doctor do not touch you in any other way that is not professional. I'm palpating the area that you told me that you have pain, that you have a bulging, that you have an injury, because I'm going to see what it is, how it feels like, and how you respond when I palpate to that area. See, when I have a patient, it says this leg, oh, I have this leg hurts. So I'm going to pretend I'm going to move the leg a little bit to see whether the patient, I'm going to elicit any pain. So the patient said, oh, no, don't move it much. Oh, don't press much. It hurts right there. So now I know exactly that that's the reason that the patient is here. So that is the complaint. Now I'm trying to figure it out. What is it? So this is just palpation. Using touch to detect abnormalities. Remember, usually we use it just to feel something that it looks normal, but underneath the skin, underneath your muscle, something must be going on, or underneath your abdomen, all these organs, when I press your abdominal area, probably something is going on. So palpation is just touch. You're gonna palpate, but we don't tell the patient, okay, Mr. and Mrs. Smith, I'm gonna touch you, okay? That is a no kind of statement. You just said, I'm gonna palpate. If you don't wanna say palpate because the patient probably is not gonna understand, use the word feeling. I'm gonna feel this part of your body. Tell me if you feel pain. I'm going to ask you to raise your left arm all the way up. Oh, no. It hurts when I try to move it. Okay, no problem. Leave it there. Then I'm going to do it myself. I'm going to raise your hand. I'm going to try to raise it, helping you out and see where's the pain. So I'm going to palpate in the arm, the shoulders, the hands, everywhere to see where is the pain. Where is the pain elicited? So that's basically what it is. So palpation. So here is palpation. See, palpation is to touch or feel the patient's body for abnormalities. All of these are techniques for examination. So this medical provider is palpating, feeling the abdominal area to see if the organs are the same side, they are swollen, that's where the pain is at. What is it that you feel? Whether there is too much air, whether the organs are enlarged, or you have gases, or whatever it is that is causing you the complaint that the patient is there for. So for you, it's just to understand the terms. So you're gonna have questions there. So the medical doctor is touching the abdominal part of the patient. What is the medical doctor doing? The medical doctor is palpating, or vice versa. Remember, they can use either or the term. The medical doctor is palpating the patient's abdominal area, the arms, the legs, the neck, whatever it is, whatever part of the body. What is the medical doctor doing? Oh, the medical doctor is touching the patient. The medical doctor is feeling the abdominal area. So that's how you are going to respond to these questions. Most of these questions, fortunately, they are straightforward. That's it. They just give you a little scenario about what the medical doctor is doing using these terms, and you just have to find out what is the layman term that they use to replace this term, or what is the medical term that you use if they use in the layman term. So that's basically what it is. Because remember, medical doctors should not be telling the patient, I'm going to palpate your abdominal area, not touch your abdomen or your belly or your stomach to see if you develop any pain when I press my hands against your abdominal area. So that is called palpation. See, I'm not the type of person who's okay, just learn palpation means to touch. If you don't see it, if you don't understand what is the medical doctor doing, then when you get the questions, you're gonna be lost because you don't know where to apply this. Oh, palpation means touch. Yeah, but you're not gonna be asked, oh, palpation, what is it? Touch. No. They're gonna give you a little case scenario when the medical doctor patient is touching the medical doctor is touching the abdominal area of the patient. What is the medical doctor doing? Medical doctor is palpating, or vice versa. The medical doctor is palpating the abdominal area of the patient. What is the medical doctor doing? Then you're gonna say touching the patient, touching the abdominal area. So that is how you are going to respond. Remember, these are straightforward questions, not complicated. But because too much information, that is why, I'm kind of, go over this and explain you this and tell you what possible questions are you going to have in your exam, because I want you to focus on those particular, terms versus just to read the entire book or chapters and then, not do well. So number 3, percussion. So once again, probably you don't even know what percussion is. Well, I didn't know anything when I went to medical school. Percussion, what is percussion? I know what's inspection, palpation. I didn't know how to use it in medical. So percussion, I never heard about those words. If I heard, I didn't know what it was. So percussion means to tap. So this is tapping. So we're gonna see what it is. I'll tell you how that works. So when the patient complains about some problems with the abdominal area, particularly the abdominal area, these spaces, when you have organs, like the lungs, the abdominal cavity. So we are going area, or they feel bloated within the abdominal area. They being coughing. So we're going to check for whether there is liquids or some infusions in there instead of just air, or whether you have, an enlarged organ, or you have swelling. So that's basically what we do the tapping for. So here, that's how it's done. So now, probably you never see this before. So what the doctor does is here, the doctor is tapping the patient's chest. So we are trying to figure out if the patient has liquids inside the thoracic area where the lungs are. So the patient, the medical provider place their hand, the plan of the hand right here, so over the patient's chest, then they take the index fingers and they start tapping. That's tapping. And they're gonna listen to different sounds, whether there is liquids and where it's supposed to be air, or there is a mass, the patient has a tumor inside. So we are going to have different sounds when we do this particular tapping or percussion procedures or techniques. This is not for anyone else. You have to be trained to do this, to understand, what it's like feeling this place that is filled with air, because the chest is a cavity where it contains certain organs. The abdominal is a cavity. That's what it's called, the chest cavity, the abdominal cavity, the pelvic cavity. But we do not tap in the pelvic area. We don't do that. We don't tap anything underneath here. We do the abdominal area right here, the chest area right here, and the back of the patient on the thoracic, because it's where the lungs are. Any other parts, we're not going to, they're not cavities. The legs are not a cavity. Cavity don't do it because here to talk about it. So that's what it's all percussion, which is called tapping. So you are going to have a question in your exam when they're gonna ask you. The medical provider is applying the percussion technique. What is the medical provider doing? The medical provider is tapping over that area. So tapping is the answer. When you hear percussion, they're not gonna ask you about putting the fingers right here, putting this, putting that, nothing at all. It's just that you need to know the layman term for percussion, the layman term for inspection, the layman term for auscultation, and all of that. So again, you just need to know what the layman terms are because we use the layman terms. We're gonna tap right here, okay? Because we as medical providers, we explain the patient what we are going to do. So do you. So whenever you have a patient that you're gonna do procedure, or you were ordered to do something or to prepare the patient, you have to explain to the patient what is it that you're gonna do. Don't just go there and start doing things. It doesn't work that way. Okay, any questions about percussion? Remember, the only thing that you need to know, what is percussion, layman term, that's it. Tapping, percussion, percussion, tapping. That's basically what it is. Auscultation. Remember, I highlight them. Why? Because all these techniques for physical exam are going to be asked. Because we need to know. So these are simple terms. It's just that when we are not used to, they do not look simple to us. But in reality, these procedures are very simple because you don't have to do it. You just have to know the procedure. So the medical provider is auscultating the patient's lungs, is auscultating the patient's bowels, is auscultating the patient's artery sounds. We can auscultate a lot of stuff. So the most common ones are the lungs and the bowel sounds. So the abdominal area, so the intestines, when I hear their sounds. So auscultation means listening to sounds. That's it. So the questions are, it can be either or. The medical provider is auscultating the patient lung. What is the medical provider doing? Is listening to the sounds. The medical provider is listening to the lung sounds or just to the sounds of the patient's lungs. What is the medical provider doing? Auscultating the lungs or the bowels. So basically, that is what it is. Once again, very, very, very simple terms. See, auscultation. All these procedures are done by the medical doctor. What is auscultation? To listening, to hear sounds. Now, another question, here it is. What instrument the medical doctor is gonna use to listen to the lung sounds or to auscultate the lungs? A stethoscope. And stethoscope is used to listen to body sounds, any sounds that we're going to listen to. So we have heart sounds, lung sounds, bowel sounds, arterial sounds. All those are sounds, and we listen to it. And we use the stethoscope for that purpose. So remember, right here with auscultation, you're going to have two questions. One is, what is auscultation? The other one is how you perform auscultation, which is using an stethoscope. So that's how usually works. Any questions about these different techniques or methods for physical exam? Because they are very, very common, remember. Inspection, this is just, once again, observing the patient, looking at the patient. You don't need to touch it because to touch means, remember, to palpate. So that's basically, this is to touch. This is palpation. Precaution, remember tapping. If you are tapping over the patient's cavities, then trying to find something abnormal there. Auscultation, remember, is hearing the lung sounds, but mostly we don't say hearing, we use listening to the sounds or listening to the, body sounds. Remember, the most common things that we auscultate or listen sounds from are lungs, heart, the bowel sounds, the abdominal area, the intestines, and the arteries. We use these techniques to do this particular physical exams. Any questions again about these particular procedures, techniques? Okay, we're gonna move a little bit in a different direction because now it's gonna be your turn. Some of the procedures, laboratory procedures that you're gonna be conducting. So particularly, there is one of these procedures out of 4 or 5 that we're going to talk about that usually you are going to encounter yourself in your job, so that you have to do it. So let's move on and talk about this. Vision testing. So now this is the part of the medical doctor. So the medical doctor is going to evaluate, but you are going to do certain very basic visual testing for the patient. For now, we're just going to start with the medical doctor. Then the medical doctor is going to evaluate the patient's visual accuracy. Now, this is one of the things that you're gonna do because we're going to evaluate. So the test you're gonna be doing, but the actual ophthalmological exam is gonna be done by the medical doctor. So the patient comes to the office, and then immediately based on the chief complaint, what exactly the medical doctor is going to order, what the medical doctor is going to perform. So I have problems with my vision. I cannot see through this eye. My vision is blurred. I have something that fall off in my eye. I can barely see. It's burning. It's itching. Whatever the case may be, I cannot see to this eye. Blah blah blah. So then right, you have to prepare the ophthalmoscope. So you have to get everything ready for that purpose. So it can be done as part of the general physical exam because general physical exam is the same as complete physical exam. Every single time that you go for, to see a doctor for the first time, and every year after, we're gonna do a complete physical exam. During a complete physical exam, we're gonna do all these basic tests because we need to know how you're doing in general. So that's basically what it is. Remember, the medical doctor is going to use an ophthalmoscope. Remember, ophthalmo means eyes, scope means instrument. So this is an instrument that is used to visualize, to view inside the eye. It's not just to look from the outside. No, we're gonna see inside, all the way back of the retina. So when we take anatomy and physiology, and we are talking about this all the parts of the eye inside the eyeball, which is the inner layer of the eye. For those who took anatomy and physiology, already know that. We also are going to find the optic nerve, which is right here on the back of the eye. So now the optic nerve is the one that connects the eye with one of the major portions of the brain that is in charge of controlling vision. Because remember, optic means eyes. So that's basically what it is. So we're gonna see what is the problem, because you say that you have a loss of vision, right? Or you have a blurred vision. We're gonna see why is it that you cannot see whatever you could see before. So now we're gonna check it out. But that is the part of the doctor's job. We're gonna see the blood vessels that are located inside these layers of the eye. So we're gonna see if there is any damage to those blood vessels that brings blood, brings nutrients, brings oxygen, and that is the reason why you are losing your vision, because you don't have the nutrients to keep all these tissues of your eyes or muscles healthy, right? So that's basically what it is. So that will be the job of the doctor, to do this all the ophthalmic examination. So once again, but then you're gonna have parts of this that you have to do. So here it is. The medical doctor is using the ophthalmoscope. Remember, ophthalmoscope, these are questions for exam. They're gonna ask you, what is the instrument used to check the patient's eyes? Ophthalmoscope. What is the instrument used to check the patient's ears? An otoscope. What's the instrument used to listen to the body sounds? A stethoscope. And of course, as we move on with all of these lectures, we can encounter other instruments that you might be asked during examination. Remember, this is the part of the physical exam that the medical doctor is going to conduct on the patient, but you're going to be there assisting the medical doctor, and you're going to be preparing the patient, preparing the equipment, preparing the supplies for the medical doctor, depending on what is it that the patient is complaining about. If the patient is just having the regular physical exam, then probably you don't need to be there. Probably you have to do some of the procedures, but during this ophthalmologic examination, you don't have to be present. So that's basically what it is. Snellen eye chart. Now, this is something that you have to do. So you got to learn this. There are two, maybe three questions out of this particular chart that you're going to encounter in your exam. So you need to know this part. It is very, very simple to do this screening test because we're going to have a chart with some letters that the patient has to identify as certain distance. But there is a proper technique to do this test. So you're going to be able to follow the instructions. I have a video. Now I know how to get the sound, so you can watch exactly how they do it in that particular video. So you're going to be understanding how the procedure is done and why the procedure is done. So the patient comes and says that, kind of losing your vision. After the medical doctor has evaluated, then the medical doctor is going to ask you to perform this particular screening test. Says, I want you to measure the patient's visual acuity. That's what it's called. But this is a visual acuity that you're going to be doing at certain distance. So that's basically this. Use visual acuity tests in medical offices. Probably you have gone through one of these tests. I have. Sometimes think about this so I can refresh your mind. When you go back to the DMV, the Department of Motor Vehicles, to get your driver license, so to renew your driver license, they place a chart, a plate right in front of you a certain distance, and they ask you to read certain letters, certain lines. That is called Snellen eye chart. Now, where does Snellen come from? This is the name, the last name of the medical doctor that invented this test. Remember, every single time that we have a certain names there that we don't know how to explain, then, so what's an Snellen? Wait a minute. Try to figure it out. No, has nothing to do with the definition of the word. Is the name, the last name of the person who invented this test. That was Dr. Snellen. So every single time that I go over something, I tell you because this is important for you to understand so you can familiarize with this. So there are different Snellen eye chart devices. There are devices for someone who is who speaks the language. If it is English, you speak English. So then when I ask you the questions to read those letters, you can read those letters out loud in English. If it is in Spanish, well, you're gonna do it in Spanish because these are just letters. But this is for someone who knows how to identify, who knows how to read. Because remember, there are people who do not know how to read. If they don't know how to read, how are you gonna give them this chart to read the letters? So this is for people who knows how to read. So that's basically how it is. So these are the types of Snellen charts that you're gonna encounter in your office. So depends of, the population that you're working with. In medicine, we use population to identify children, adults, elderly. So that's basically what it is. That's population. So my population in the place where I work, you said I work with the pediatrics department. So your population are pediatrics. So that's basically what it is. So the first Snellen chart that we have here is called the alphabet for English speaking patients. Now, we said English speaking patients because we are in America, right? But this same chart, we can use it in Spanish and in many other languages that uses the same alphabet as English. You're not gonna use it in Chinese because they're not gonna understand what, or in Hebrew or in some other language or in Hindi. So again, we said English, but if it is Spanish, I have done this test in Spanish people, and because they don't speak English, but I do understand Spanish, so I do it. I ask them, I explain them, give the instructions in Spanish, and they're gonna read it in Spanish, and I'm going to understand. This is the first one, the alphabet for English speaking. This is the E chart, the rotating E chart. Now, this is another one. This is number 2. Now, this is for non-English speaking. If you don't speak English, so I'm going to place the letter E and I'm going to try to rotate it in different positions. And you just have to tell me by signaling like this, like this, like this, or pointing with your fingers like this, with your thumb, up, down, to the right, to the left. Oh my God, this is, sorry guys. I left my phone for the alarm is got. So that's basically what it is. So you're just gonna signal up, down, to the right, or to the left. So that's the E chart. And is used for children as well. Because little kids, they don't know the alphabet, so you are going to give this. Now, once again, all depends of the population that you have with you. There is the third one, that is the object chart. All of these are called Snellen chart. So the object chart for preschoolers. So these actually are for these little kids who do not have no idea about letters at all. So they're gonna identify objects. So charts. This is the particularly this one. You're gonna need for repeating every single time. and starts from very large. All of them starts at very large letters, and they become smaller and smaller and smaller. And we're going to see which of these numbers starts number 1, number 2, number 3, number 4. Which of these numbers, which one of these lines you are capable of reading? So that's basically what it is. The same here. I'm going to ask you, what is the direction of this? What is the direction of this? This. We're just going to point over. And the patient is going to tell us the direction by just pointing with their fingers or with their hand, whatever the case may be. And we move down until we see the last ones that they can no longer see or they cannot, point down. They're gonna say, I don't know. They start saying like this when actually it's like that, and then we stop because we know that they already cannot see these letters from the distance at which we have placed them. Here is the object 1. See, they have a little boat, a little cross, a little circle, heart, stars, the moon, things like that. So we're going to ask them to read it because the preschoolers get familiar with these little things. So it's very interesting. And all of these are called Snellen visual charts. The one that we are going to focus, because it's the one that is the hardest, because remember, this is just to identify what is the image. What image is this? What image is this? What about this? What about this? What about this? So you're pointing out to the child. And then they will tell you, oh, that's a star. Then we move. What about this? Oh, that is a heart. What is this? Oh, they're going to say this is a boat, this is a ship, whatever it is. Well, we know that that's what it is. And move on through all these lines to see how far can they read these letters or these objects or point the direction of the E. So that's basically how it works. So these are very easy, but this one is more complex, which is this one, the alphabet one, because here we need to understand most of the things that are here and how to prepare ourselves, because we need to learn first so we can test the patient. And we use the appropriate technique to make sure that the patient knows what they're doing. Because other than that, we are going to have a wrong results. If we don't know what we're doing, we just randomly going from one place to the next. No. This chart needs to be done appropriately. So we need to understand each line. And do the patient has to complete all the letters in each line for us to count that as, that visual acuity for that patient in that level or not? So we need to understand. So before we move to that, we're going to continue with this part. So that was just to show you how these different types of Snellen charts looks like. So the first question that you are going to have on your exam, national exam, about this is, okay, what is the Snellen chart used for? See, what is the Snellen chart used for? So you're going to be familiar with the name. Oh, Snellen. Oh, that's for vision. Visual acuity. Just think about vision. Immediately, oh, the patient is placed 20 feet away from the chart, blah, 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 because we're going to discuss that. So remember, this is an eye chart. So there we are going to evaluate the patient's visual acuity. So that's basically what it is. So get familiar with those things. So here it is how the procedure is done. So this chart is going to be mounted on the wall. You're not going to be carrying the chart. There's a different methodology to do that, which is with a small chart that you're going to put like 14 inches away from the patient. So they're going to hold the chart like a little card right there and start reading. But this is not the one that we do most of the time. We do the large chart. So every single time that you're going to do procedure, remember, for the purpose of preventing cross-contamination of infections, you are going to wash your hands. You are going to dry them off. You don't need to wear gloves for this particular test, but you do have to wash your hands. Then you're going to assemble your equipment and supplies, whatever you need. So you're going to get the card when you're going to get all the information. You're going to get the results or the medical charts if you want to have it. You're going to have a pencil or a pen where you're going to write down. You might have a ruler or a little stick because you're going to be pointing on this particular line or this particular letter that the patient needs to repeat after you point it out. Because there are different methodologies to examine the patient. We're going to go over those. Now, you're going to ask the patient to stand or to sit. Depends. If the patient has a physical disability, well, the patient is not going to be able to stand, so you're not going to force them to stand, right? But if the patient can stand, the patient is going to stand 20 feet from the chart. Has to be straight. Now, leaning forward or back, straight in looking at the chart. The chart, the position of the chart should be at the level of the patient's eyes. So think about this. If I'm short of its stature, you're not going to place the chart up because I have to force myself to look up or to the left or to the right. If I'm standing right here, my chart has to be at that level of my height. So that's how it works. Other than that, you can have false results. So that's how it works. The place has to be a quiet place. There is a line on this particular room where you're going to be doing this exam. It's not approximately 20 feet, has to be exactly 20 feet. It's already measured. It's already painted, the line right there on the floor. So you're going to ask the patient to stand up before that line. Once again, this is how it's done. So you see that position the patient 20 feet from the chart. It is highlighted, right? Well, why? Because this will be question for your exam. So remember, you are going to have a question about what is the Snellen chart used for? What is the purpose of Snellen chart? To measure the patient's vision acuity, or just measure the vision. Just go for that. That's how you are going to understand. How far from the chart, from the Snellen chart, the patient needs to be standing from 20 feet away from the Snellen chart. 20 feet. It's not 19, it's not 18, it's not 40, it's not 50 feet, it's 20. That's how it is done. That's the correct way that the test is going to be performed. So don't forget, it is 20 feet away from the chart. So the patient is going to be standing 20 feet far away from this Snellen chart when you're going to be testing the patient using the Snellen chart. So that's how it works. Any questions up to now? Probably you have these tests already. I have them, and I have performed these tests so many times. So I haven't done it for a long time, but now only when I train my students, but not physically because I'm not active medical doctor anymore. Okay. So this visual acuity test, it is for distance, because remember, this is a distance visual acuity Snellen chart, because you're gonna be standing 20 feet. It's not 20 meters, it's 20 feet away from the chart. So that's basically what it is. Now, what else we're gonna do? Because remember, we have to instruct the patient how the procedure is going to be conducted. So don't assume that the patient has this before and the patient kind of, oh, I know what it is. They say, okay, let's review a little bit. You're gonna be standing right here. Don't tell them you're standing 20 feet. That's no need, because there's a line right there. So, sorry. There's a, something went to my. So the thing that you're gonna do is, once again, the line is there. So you're gonna ask them to, let me drink a little water because my throat is dry for talking too much. Sorry, probably that's what it was. Been talking and talking and talking, and I didn't drink anything, so it gets you. Okay, so going back again. So the line is there. So you don't have to explain the patient, okay, you're gonna be standing right here, 20 feet away. No, that's for you. That's for the test purposes. To the patient is, please stand right here behind this line, straight, looking forward. Don't lean forward, just look at that chart over there on the wall, because you're gonna be reading some letters when I ask you to do so. So that's it. Now, remember, there are different steps to start reading these letters from the chart. You can start anyway. You can start by reading with both eyes first. Open both eyes. Okay, can you read that? Then you can ask them to cover one eye. It might be the right, it might be the left. You ask to read one of the lines. You're going to give them the line. Or you're going to ask them, see, like here in this chart, which of these number lines you can read? Well, you have to be blind not to see the E or the F or the P. This is for just blind. This is a huge letter. Now you're gonna tell them what are these numbers? You can read which line you can read from these numbers. Said I can read number 7. See, so this is number 7. Then you can ask them to read it from left to right. So then you're gonna say E, D, F, C, Z, P. So correct. All of them are correct. Then you move to the next line, number 8. So that's how you do it. And if you pass the 8, you move to number 9. But if you get blocked right here in number 8, you didn't complete it. Or you completed it, you go to the next one, number 9. Oh no, I cannot see those letters. Or here, number 8, you start reading. oh, E, E, I, oh, no, that's it, you lost, that's now. So you're not gonna say anything until they finish the entire line. Then you tell them, that is okay. Now let's switch eyes, move to the other eye, and you tell them, you ask them which line they can read. That is one of the methods. Also, you can ask them. This is the method that I use the most. I point the letter that I want you to repeat from the line. So if you select line number 7, then I'm going to point out with a little stick. Okay, what letter is this? Then I said, oh, D. What about this? E. What about this? F. This one. C. This one. P. This. Z. Now, I'm not talking, I'm just explaining you, but I'm pointing it out with a stick. Okay, can you read this one? They say E, F, Z, but you have to go over all the letters. It's just that I jump on them. Why? Because some people try to memorize these letters before they go to the medical doctor. And they just want to read it straight up. But if you randomly select them, then they're gonna get lost. They don't know. They know the sequence, but oh, start hesitating. They're not gonna know. I'm telling you, this have happened. So it is very important that you do that. Now, let's continue with this, because how do I know what is your visual acuity? Your visual acuity is marked right here on the left. This is it, these numbers. These numbers. These numbers are this represents each line. So this is the number that I'm going to record when the patient completes reading this particular line. So this, if the patient reads this one, remember, number 8 or number 7, whatever the case may be, then you're gonna give them that number. We're going to talk about that in a little bit. I don't want to give you too much information right now because we are going through the process of reading the line first. So now the patient went up to number 7. The whole letters were complete. That is line number 7 that was complete. Now, what about line number 8? Can you try? The patient goes here. E, E, L, O, P, Z, D. Well, they have two wrong right here. So if they have two wrong, that is the maximum wrongs in one line that you can accept. So the patient is line number 8. We're gonna do a little something there. Now the patient has 3 wrong. If the patient has 3 wrong in one line, that line doesn't count. We go back to the next one, and instead of being 8, it's gonna be 7. Because 7 was the line that the patient read all the letters correctly. Number 8, the patient fell 3 letters. So if he fell 3 letters or more, that's it. You don't. That line doesn't count. So you are number 7. So that's how you are going to read this chart. It sounds complicated at the beginning because remember, this is new for you. You're probably reading this, but you don't know how to interpret them because you need to get the results for the patient, not to tell the patient, but to give it to the medical doctor. The medical doctor is going to determine whether they're going to send you to an ophthalmologist or an optometrist for glasses or whatever the case may be. So that is the next step. So remember, you can have up to 2 errors in one line to, count that line. But then, depends on the number of errors, we're going to do something else in the answer. So that's basically what it is. Here is written that information because I want you to know. Here it is. So the patient is going to read with both eyes, then they're going to cover one eye, they're going to switch to the other eye. And remember, the patient needs to stay straight. If the patient start like leaning forward, like when you can read something. So when you cannot read something and you're trying to lean forward, like, oh, squinkling, can I see that? Or no, you can't do that. That's it. The test stops. I said, that's fine, Mr. or Mrs. or young man or the name of the person. That's it. Enough. Let's switch to the other eye. One more thing. If the patient is wearing glasses, the patient needs to read the chart with glasses because the patient has already been prescribed glasses because the patient cannot read something that is far away. So for that reason, they need glasses. The small print, they're not going to be able to read it. So you're not going to ask them to read without glasses because then what is the purpose? They cannot read it. That's what they have glasses already. So you have to ask the patient before you start the test. Why? Because some patients do not wear their glasses because they don't need it to walk, to move around. They need it to read. If you need it to read, then you just don't wear your glasses. But if you are wearing your glasses, keep them with the glasses. But you have to ask, remember, Mr. Smith, do you wear glasses by any chance? Reading glasses. Yes. Okay. Can you please put them on? Now you can read with your glasses. That has to be done that way. So basically, that's how it is. Remember, you're going to ask the patient to read those letters that you are pointing out or the line that you're asking the patient to read aloud. They have to do it. Now, remember, the patient is going to continue reading any lines, any numbers, until the patient fails more than two questions, more than two letters. If you have two errors, that's as far as you can go. Remember, you can have two wrong letters that you read. Everything else on the line, you read correctly, except for two the letters. One or two, that's it. Two is the maximum. So that's how it is. Now remember, it's in yellow. So that means that this is a possible question for your exam. So you got to make sure that you understand that the patient is going to be placed 20 feet away from the chart. That's number one. That the Snellen chart is to measure visual accuracy. That's number two. Now, number three is how many errors the patient can have on that particular line when they are reading the Snellen chart. Two errors. Up to two letters, you can miss. Anything else, if you miss more than one, that line doesn't count. We go back to the anterior line, and that is the results that we are going to give you, because that is to chart the results. So to chart the results here, what it's telling you is document the results. Has nothing to do with the Snellen chart, no. Now is document the results. Because remember, documentation in medical, we can say, I'm going to chart, I'm going to do the entry, I'm going to document, or I'm going to write it down. All those terms are synonyms. So we can use them interchangeably. So that's how it works. So let's see, we're going to watch a video how this is done so you can have an idea. I have like 3 videos right here that we can watch to do this particular test. It's very simple, but once again, when you haven't done it, well, it's not gonna be simple at all. So paste this, say, Oh no. No, this one here. Did I mix them up or what? It was another video for the next. Yes, this is the one. Okay, so let me. Okay, so here is the video. Now it has a sound because I'm pretty sure it does. Okay, so we are going to perform a patient screening test using an established protocol, measure distant visual acuity using the Snellen chart. So that's basically what it is. So this video is from the same PowerPoint presentation that I have. Okay, so let's play it.
In this procedure, you will learn how to use a Snellen alphabetical chart to determine a patient's visual acuity at 20 feet. Prepare the area. Make sure the room is well lit and that a distance marker is 20 feet from the chart.
Hi.
Hello.
How are you this morning, Jubilee?
I'm good.
Good. Can I get your full name and date of birth?
Jubilee Leanhouts.
To make sure you have the correct patient, identify the patient by name and date of birth.
I'm just going to sanitize my hands quick.
Sanitize your hands. Explain the procedure.
All right, we're going to be doing a vision test today, and I'm going to have you use this occluder to cover one eye. So you cover one eye at a time. You can go ahead and hold that and give it a try. There you go. That's what we need you to do. And while you're covering that eye, I'm going to have you looking at a chart and reading the different letters that are on the chart. And they're in a number of different lines. We're just going to have you work your way down. And then when you're done with one eye, we're going to move to the other.
Instruct the patient not to squint during the test because this temporarily improves vision.
And it's important that you don't squint while you're doing the test because that can affect your vision, and we want to make sure we're getting a true picture of it.
If the patient wears corrective lenses, they should be worn during the test. Be sure the patient does not get an opportunity to study the chart before the test is given, or the results could be affected. Position the patient in a standing or sitting position at the 20-foot marker. Check that the Snellen chart is positioned at the patient's eye level. If the occluder is not disposable, disinfect it before the procedure starts.
All right, Jubilee, we're going to check your vision now, and I'm going to have you use this occluder to cover one eye at a time while we check your vision. And so I'm going to have you start by covering your left eye.
Traditionally, the right eye is tested first. So instruct the patient to cover the left eye with the occluder and to keep both eyes open throughout the test to prevent squinting. Stand beside the chart and point to each row, having the patient read it aloud, starting with the 2070 row.
Z.
Good. How about here?
LPED.
Starting with larger letters gives the patient confidence and allows her vision to adjust before moving to the smaller letters. Proceed down the rows of the chart until the smallest row the patient can read with a maximum of 2 errors is reached. If 1 or 2 letters are missed, the outcome is documented with a minus sign and the number of errors. If more than 2 errors are made, the previous line should be documented. Any of the patient's reactions, such as squinting, leaning, tearing up, or blinking while reading the chart, as they indicate she may be having difficulty with the test. Repeat the procedure with the left eye covering the right eye.
And one more.
Then repeat the procedure with both eyes uncovered. When you are finished, disinfect the occluder with an alcohol wipe if it is not disposable. Again, sanitize your hands. Document the procedure in the patient's record, including
the date and time, visual acuity results, and any reactions by the patient. Also, record whether corrective lenses were worn. Procedures must be documented to be considered complete.
Okay, so it was easy to follow, to understand, because it is a very simple procedure. We just need to be familiar with the chart and with the instructions that we're going to give to the patient, so the patient can follow those instructions correctly. So that is the key. You're going to get really well as you start practicing doing this particular testing. So don't be afraid to, to practice this, to make sure that you understand. Now, let's go back to this chart and see what was the two errors. Remember, as you saw that everybody is going to have a different technique. See, you can ask the patient as, the video repeated. You can ask them to start reading a line that they feel comfortable with. Sometimes you have the initiatory because you're working. You don't want to start with line number 2. Okay, line number 2, because you're going to spend too much time. So the best way to do it is asking the patient which line they feel more comfortable to read. And you tell them, line number 5, do you feel comfortable reading this line? So you point at line number 5, or line number 6, or 7, or 8. Because remember, time is very important when we're working. Yeah, I can start, okay, what letter is this? What letter is this? What letter is this? Well, you're going to spend there whole an hour there. There is no need for this. So basically, that's how it works. Now, usually, pay attention to this, because if the patient is wearing glasses, you already know that the patient has some time of vision problems. That is the reason that they have these corrected lenses. So start with these letters, like line number 6, but don't go up because it's too much. And once again, you can point the letters, or you just can ask to read the line. Now you have to be close to the chart, and you are seeing that whatever they're reading, that's exactly what is there. So don't take the word for just because they're reading it. No, you have to be checking yourself. If I give you line 9, number 6, I have to be paying attention. When I place this, I know it is a P. So I want you to repeat the P. And this is an E. And this is a C. This is an F. This is an D. So for that reason, I have to be there checking, not just listening. They might be saying something else. So once again, that is how it works. Any questions? Now, let's talk about these numbers on the left. Oops. These numbers right here on the left side. So here we're gonna have numbers. So I'm gonna go right here, it starts right here. So this number right here, you can go and check it out on your PowerPoint presentation. It says this is 2200. See, this is number 1. So if the patient only can read this letter, the patient visual acuity is 2200. What is 20? 20 is the distance at which the patient is standing. Remember, the patient is standing at 20 feet, right? This is 2000. So this is 2000. This is 2075. See? So all these means something. So this is the number you're gonna point them out to read, but these are the results. These are the results from the patient. So if the patient can read only this letter, the patient visual acuity is 20/200. Every single number, this is 20/60. 20, 20, 20, 20, all of them have 20. See? 20 over something. Because 20 is the distance at which the patient is standing. So that's another question for exam. What does the number 20 on the results, or number 20 over 20, or 20 over 25, or 20 over 60, what does 20 means? That is the distance at which the patient is standing to perform the test. So remember, the first one, line number 1, right here, is 20/200. So that means that this person is standing at 20 feet. And the distance, this will be how bad their vision is. This is really bad. Because remember, normal vision is 20/20. And 20/20 is down here, line number 9. That's 20/20. So can you imagine any above that, you don't have a good vision. So somehow right here, you're gonna have some problems. So the number 20, remember, on top of each of these results is going to explain the distance. The other one is how far someone who can read, see? Someone normally can read, once again, from 20 to 20 distance because you have a good vision. So 200 is how far this person is going to be standing. Like a normal person will be standing at 200 feet and is going to be able to see this letter. Versus you that have this problem, you standing at 20 feet, and this is the results. So if you see this letter, if you are 20/20 vision, then it means that you are here. 20/20, number 9. So that means that you can see from 20 feet distance these letters. This person here, anyone can at 20 feet distance can see these letters. The other one, remember, me, I can see from 200 feet, I can see this one. If I put someone 200 feet to see the E, they're not gonna be able to see it, right? Why? Because they have poor vision. That's basically what it is. So in other words, the numbers right here that are, identify the distance at which the person with a normal vision will see these letters. That's basically what it means. So the results that you're gonna document are these results. If the patient read line number 5, so what will be the results? 20/60. That will be the results. So the patient is 20/60, and that's what you're gonna write down, 20/60. Now, pay attention because here is where the two errors come to play. If the patient has one error, because you have to have maximum of 2 errors. So let's put this in this way. So you are line number 7. So let's put number 7. Let's remove all these from here so we don't have all these cluttered right here, and we can understand how this works. When we come back from break, we're gonna go back again to this because you need to understand how this works. So The patient is 7. Number 7, this line, the patient read number 6 completely. P, E, C, F, D. But then the patient was asked to read number 7 because you need to continue until they fail maximum 2 letters. So the patient start reading this one and he makes or she makes a mistake. Here it says E, D, F, O, Z, D. Oh, this one is wrong and this one is wrong. So it has 2 wrongs. So the patient still qualifies for line number 7. But because it has 2 wrongs, the patient is going to have, remember, patient is going to have 2060, 2060 minus 2. See, because 2 were wrong. If it was only 1 wrong, then it's 2060 minus 1. That's basically what it is. So it was 1 wrong. That's how you have to record it. So you have to read all the lines. If the patient did all of them right, number 8, and when it came to number 9, all of them are wrong, or 3 or more are wrong, this line doesn't count. You go back and just put this one, 2025. So number 8 is 2025. That is it. But if it has 1 wrong, 2025 minus 1. If there is 2 wrong, 2025 minus 2. That is how you are going to record the results. Any questions? And you do the same for the other charts as well. For the rotating E and for the object chart, do the same. You just go through all the little objects in that line. If you miss 2, then minus 2. You mark the numbers because the numbers are the same on the left side, 20, 20, 20, 20, something else. So that's how it's going to work. Do you have to memorize this chart? No. You're going to have the chart right in front of you. The only thing that you have to make sure is that you are explaining, directing the patient correctly, and that you checking that the letters that they're pronouncing are exactly what you're pointing out. So that's basically how this chart works. So that is it. So remember, 25 means that the patient is standing at 20 feet distance. That's it, 20. And their vision is 25. So that is how it works. And if you have 1 error in that line, minus 1. If you have 2 errors, minus 2. You have more than 3 errors, doesn't count. You go back to the prior complete answer. That's it. The test is over. So that's how it's going to work. And then you're going to mark right eye, because remember, we're going to include the eye. Right eye, 20, 20. Let's put it this way. Left eye, then it's going to be 20, 25. Or 2020. Both eyes. Just be something and then something else. Both eyes, then whatever you get when they were reading with both eyes. So you have to independently mark for each eye because our eyes do not see in the same way. Some of the times they do, some of the times they don't. Sometimes you have deficiency on the left eye. Sometimes you have deficiencies on the left or right, or both when you're looking at it. So that's basically what it is. So that's how you are going to record this. So later on, we're gonna kind of go over something else. And if you have any questions, you're gonna let me know. And we can go over this chart again if there is a need. Any questions? Okay, so we're gonna take a break. We're going to come back 7:50 and continue with this chapter, okay? All right. Any questions before we go for break? Good. Enjoy your break. See you then, 7:50.
Okay, teacher.
Thank you. Take care.
啊，然后你们就那啥，你去问问去。
你说了以后我给你录音，你要不是说实话，我要
你怎么录音？你说吧，我咋录音
用我微信。
啊？然后咋的？
我是雷蒙德。
喊，姥姥个人喊啊，喊我可闹心了。
虽然世界好大，可我的幸福好小，有你的陪伴刚好，想和你碎碎念念唱一首。
到一周，
做不到，另外一个是否再相守？等到天不上一步就
全部
我要我和你说，
见到
有一天。
见到，
哎，你告诉老别说话了，数字都整不明白，还在这是。
那你要是1000话，你家
亲爱的，世界太吵闹，做自己就好。总有人看你做杂草，或者是珍宝。困了就快快睡觉，累了给自己拥抱。
4岁到16岁儿童提供每人500元也，哎呀妈呀，那我家张弛没有了。目前经费。
你知道，就算大雨绕着这城市颠倒，我会给你怀抱，牵不到，再见一杯泪倒，写下我雅如云来的味道。就算这个世界被寂寞绑票，我也不会被。
4岁的是给1000块，你6岁给500呀？哎，都快发了，告诉你了吗？
告诉什么？
啊，那什么的。那个有利息的咋办呢？
拿出来他给他，
啊？
调出来给他。
到时候一定。
是我觉得2025年很治愈我的一句话，你能把这句话刻进脑子里很好。有多少姐妹经常之前2024年你们都跟我说雪儿姐喜欢他怎么办？姐喜欢他怎么办？姐我喜欢他，不知道他怎么想的，怎么办？把这句话记住，先问，被拒绝了再说。全屏给我打出来，先问，逗号，被拒绝了再说。老年心理真的，你真的老年心态，你不问，永远就是没有答案。我今天看到一句话，是我觉得2025年怎么能让女人心死呢？那必须是女人，你不破情关，老天就会重复我们犯不成的伤害之罪。而自己就成为别人所讲的怨妇，其实是女性要学习着什么自己不。这样影响生命的习性，心中心内小心，失去了理解，就是可害怕。实际上，没有怕，你应该直面面对。言语里提到关相关，这个
你把我这个给他寄读接过去啊？
啊，
我那什么，
我后想想怎么给他结，我就忘了。
洗完了。
都写了哈。
啊
啊
啊，
给乡里了，叫他来一起了。
没洗，看在那儿，冲你没看见的。
怀疑我这突然肠胃不知道是咋回事儿呢？不知道。那我这两天干活擦东西累的，哎呀，太忙了。
就是我是这要说那谁那个臂杆那没啥意思，花点事儿
坚决不同意，
啊。
坚决不同意。哪有那么多实权是？干呗。
样子，把自己交还给自己，维留到自己样子。你一个人的时候，你会觉得很开心。如果你一个人就是不开心的，那么好，你跟谁在一起都不可能真正的喜。可以在。
电动滑声音这段话，印象深刻的就除了视频录外，在这时的片让我爱人玻璃。这些。
真的不知道你是这么想的。你要感谢他，断了你所有的后路。人活得太卑微，男人太渣。可是事实上，人性就是这么。其实往往最长久的男女关系是关系，他都有可能有分歧，因为他对彼此都有帮助。多难也算是看不到，这个超越这一层，而是灵魂上的。我是正太在我自己的站在这个块，所以我就跟他们聊这个干嘛？但是我为什么觉得很麻烦，还受伤害？我非常非常惊讶，我也自己谈过恋爱，相信就谈恋爱就是曾经有过多少欢乐的经历。如果你害怕是个有可是人生难道不生活？
这个大新的事实，对。小时候你不能这样，就需要了。
这不召唤，他有情绪，你得让他。
这句话点醒了，女性最有力的内核不是外表，而是千锤百炼后的温柔，是经历磨难后的大气，是代表着超强的情绪管理能力，是4两拨千斤的沟通能力。
女的会有，我觉得一个艺人要清楚。
慢慢倒。
有放在一个尤其是一个女孩子，如果有一个非常非常爱她的父亲，这个女孩活在世界上会很有勇气；如果有一个非常非常爱她的妈妈，这个女孩会很懂得自重、体会懂得爱是轻松。然后，我爸爸给什么立场？
千万别大意，
我不要需求吗？我到今天，我知道现在男的，
果然，想逗一个人的眼神是藏不住的。上刷练体能的时候，在跑步机跑步，刚开始还很正常，跑着小格子给莎莎单独调快了。
经常说这种话的，一个家突然散了，是怎么回事？
以为有能量的女人，谁娶她谁享福，谁靠近她谁发财。有能量的女人，她是什么特点呢？第一个特点，她天生就自带着一种说不出来的气质，骨子里就有不输没关系，可以同在。第二个点呢，就是不愿意同流合污，别人耍心机那小绿茶了，他不爽，他也懒得苟同。我选择我真诚，我选择我实在，我就在我自己的世界里真诚和实在就好。然后第三个点呢，就是他们一般不爱显摆，我有什么我自己知道就好，也不介意别人，你有是你的事儿。第四点就是有自己的想法，有自己的主见，不会说随便一个闺蜜一来煽动就变了我的想法，内心对一些东西是很我30岁的时候。我要你是吧？
但是有人有了情感。
你闺女怎么还没回来？宝贝儿，贴着
对呀，装红包，说没有那个红包那个。
星座大概就是水瓶座。
嗯，
你看他每次宣传，这个时候是因为
你明天你要唱天管要都要一单，他那有。
叫婆婆强势怎么办？睡不着觉，失眠去。我跟你说实话啊，在婆婆面前，如果她对你态度不好，或者如果她对你就是指手画脚，说明什么？说明你老公没有在她妈妈面前说你好。你们认为？
其实女生流泪大部分是在哭泣。
借钱就是花钱买罪受。我只要跟我先生吵架，我第一个打电话。
一个女的，她有几个反驳，男人非常有反驳。
找一个有钱的大把的数，找一个没钱的，除了没钱什么都好。但是我就必须没钱，该怎么办？人不能是要不要的。你想咋？你想你找一个没钱的，什么都有，对，我告诉你，那个你怎么选，你都会后悔；你怎么选，你都会后悔。我发现所有的伤心难过痛都消失了。我实在偶尔看到婚礼他的消息才想起来，这个闪闪发光的前任是什么？它就是我们记忆里的一颗星星。如果你飞4手就刻下一颗，你的回忆多么暗。你们还年轻，你们以为让前任过得鸡飞狗跳就是对自己最大的安慰吗？过得比他好就能让遗憾少一点吗？我告诉你们，不会。恨不是爱本身，恨是爱而不得本身。不管你们曾经多么真挚、多么热忱、多么不要命的爱，我们必须承认，他爱你是一种选择，他离开是一种决定。当分开了。
被这句话点醒了，你没有任何人把你变成你越来越好的原因，从来都是因为你不断反思和一次又一次的拯救自己的牢骚。被这句话点醒了。
一切一个就发生了，不论是一定会发生。
强自情绪的打击他们。黄圣依没有特别强调自己想要什么，是在说希望孩子能够有足够的父爱的时候崩溃怎么样，都不希望儿子以后多。无论任何关系。这些年真辛苦了。孙玉桥暌违23亿在场录节目，在节目里说，他每天晚上都为求实现让人2个小时。这件事已经持续5年，直到去年才停止。年前他们前夫表演就应该应该想起这些，他都要被领导上头。我说，反正不解，不正，只能回应我的观点。
歌德曾经说过。
要站在足够高的位置，
我来把那里全部的大概都知道。
一个人从来期待到闭口不言，他都有多失望？你总觉得，你有没有发现，人在以后真的只需要用直觉去。
都看不见我，我一个人。
千万不要看，不要怪别人，不要怪人心，而是我那个想改变的心情。我没有任何理由走到今天，唯一的理由，我给同龄代的人加乐观。 更加会找乐子。
可以支撑你很久的情怀，往前走，不烂在过去和梦里。你们知道这个事情背后的故事吗？当时莎莎发生了惊神，大头先出手，摸了摸她的脸，莎莎不知道跟大头说什么，最后大头直接搂着她，吻她的脸蛋，还很贴心的把莎莎衣服拉链给拉上了。他俩在一起这么多年，很少能见到他们在公共场合做这么亲密的动作，这是当时本人分析的建议，可能大头也没想到，可是这么远都会被猜吧。我最近看到很有感，
恨那个伤害过你。目的，比如说我要搞钱，我就是要搞钱。那么我所有的情感的手段都是假象。搞不到钱我就撤，情感上面会过得去。如果我要搞情感，就拿钱，钱就变成手段。这个逻辑你听不听得明白？也就是说，一个人想要让对方恶，就捧他；想要让对方好，就骂他。目的和手段永远是相反的。如果你想搞钱，就给他情绪价值，好，赚钱。如果你想让这个人开始正心正念，就用钱去栽培。所以谈感情伤钱，谈钱伤感情。目的和手段永远是相反的，这是事物的一分为二，这是高级思维。人不要用情绪跟别人对话，要用理性跟别人对话，找出线头来。你的目的，比如说我要搞钱，我就是要搞钱。那么我所有的情感的手段都是假象。搞不到钱我就撤，情感上面我也过得去。如果我要搞情感，就拿钱，钱就变成手段。这个逻辑你听不听得明白？也就是说，一个人想要让对方恶，就捧他；想要让对方好，就骂他。目的和手段永远是相反的。如果你想搞钱，就给他情绪价值，哄他，换钱。如果你想让这个人开始正心正念，就用钱去栽培他。所以谈感情伤钱，谈钱伤感情。目的和手段永远是相反的，这是事物的一分为二，这是高级思维。人不要用情绪跟别人对话，要用理性跟别人对话，找出线头来。你的目的，比如说我要搞钱，我就是要搞钱。那么你的所有的情感的手段都是假象。搞不到钱我就撤，情感上面我也过得去。如果我要搞情感，就拿钱，钱会变成手段。这个逻辑你听不听得明白？也就是说，一个人想要让对方恶，就捧他；想要让对方好，就骂他。目的和手段永远是相反的。如果你想搞钱，就给他情绪价值，哄杀他，换钱。如果你想让这个人开始正心正念，就栽培。所以谈感情伤钱，谈钱伤感情。目的和手段永远是相反的，这是事物的一分为二，这是高级思维。 就这种感觉，我们千万不要做到这样。如果说你特别
小碗面了，糊糊的吧。
Okay, so we are back. We're gonna continue with this chapter. Any questions?
No, not right now.
Good, thank you. Okay, so little things that I add here to this slide because you just remember something. When we document, remember the results for the Snellen, the visual acuity test, we have to document, remember, as I mentioned before we went to the break, we're gonna document right eye, left eye, and both eyes. Remember which line was it? So what was the results for each of these for the eyes? So one of the things that I want you to know is that we use certain acronyms to mention or to document right eye, left eye, and both eyes. So I just want to make sure that you don't miss any of these simple, easy questions on your exam. Sometimes the exam asks you, how do you document right eye, left eye, or both eyes? Or how do you know that this is the right eye, the left eye, or both eyes when you're documenting something about the eyes? Well, we do not document right eye, spell it out like this, or R for right, or left for L for left, or both eyes, or B for both. No, we don't do that. We have medical terms. So when we are recording or documenting something about the right eye, then we write down OD. OD means ojo derecho. That is in Latin. See, OD means right eye. So when we document this information in the medical record, the results of the patient's accurate test in the medical records, we do not write down right eye. No, we do OD. And it's written on the card. OD, this is the numbers, 2020. OS stands for left eye. So that's basically what it is. Left eye, 2020, or 2025, or 2060. Whatever the case may be, whatever the results are for that eye. Both eyes, we do not document both eyes. We don't spell it out like that. We write down OU. OU means both eyes. Keep this in mind just in case. So right eye is OD, left eye is OS, both eyes is OU. So when you document this on the medical records, electronic medical records, the electronic medical records already have these acronyms there. Or if you want to call it abbreviations, which is not an abbreviation, these are acronyms. OD for right eye, left eye, OS, both eyes, OU, is going to be there. So it's OD, and then in front, you're going to put the results for the right eye. So you need to understand that this is the right eye, because it's not going to say right eye. It's going to say OD, OS, OU. So if you're not familiar with these acronyms, then you're not going to know where to record right eye, left eye, and both eyes, because you're not familiar with these terms. So that's basically what I want you just to know. I just add this. So write it down somewhere over there, so you know exactly when you see this, you know what they're talking about. So remember, this is how is written on all the templates on medical records. So you need to know that each of these acronyms corresponds to left, right, and both eyes when you're documenting this type of visual acuity. All right, let's move on. Let's talk about some of the most common conditions or visual defects. So we have the senses, which is one of the chapters for anatomy and physiology. So we're not going to discuss this in more detail. Here, you have the table. I'm just going to go over very lightly. We're not going to spend too much time reading from here because this is part of the lecture of anatomy and physiology when we're going to talk about these eye conditions. So let's talk about hyper, now let me use the marker. This is hyperopia. So hyperopia is the same as farsightedness. Now, what is hyperopia? Remember, hyper means far, high, above. So that's basically what opia means, eyes. So when someone has trouble seeing objects when they are close, we call it hyperopia. So you can see far distance because hyperopia, remember, means far-sightedness. So meaning that you can see far, but you cannot see close. So remember, we know and we heard about the term myopia. And we think that myopia is when we cannot see close. That is not true. So that is basically what it is. So hyperopia is the one that you cannot see something close, but you can see something far away. So when you go, for instance, to get your driver license, they want to make sure that you can see far distance because you're driving and you need to see the cars ahead of you. But when you're reading, when you giving classes or have to study, you need, or you're writing something down, you need to make sure that we know that you have nearsightedness, meaning something that you can see close, but you cannot see far. So these are problems with a refraction of the lenses of the eye. So one of the things that you need to know just for now, that hyperopia, hyper, remember, above, you can see far, but you cannot see anything close. The opposite is myopia, nearsightedness. Now it means that you can see something close, but you cannot see something that is far distance. These are the terms that you can have in your exam because they are straightforward questions. If someone has troubles seeing small print, not being able to read something in your book because it's too small to print, then you have hyperopia because you cannot see something close. You can see something that is far, not close. So that's basically what it is. And myopia is the opposite. You can see something that is close, but not something that is far. So that's how you have to understand it. Another one that these are questions for exam. Presbyopia. Presbyopia, pres means all, age. Opia means eye. This is an all eye. If you have noticed that when we reach certain age, remember, not everybody who wear glasses have problems seeing or vision loss has presbyopia. No, you might have hyperopia or myopia. You can be born with a defect of refraction on your eyes. So if you see a little kid wearing glasses, they have a problem with their eyes from birth. Now, if you never wear glasses, never, put yourself glasses to read or to do anything, but after a certain age, you develop this condition that is called presbyopia, because it is after a certain age that you are not able to see, because now are damages to your eyes structures. But it's because of the age. As we age, we start losing a lot of stuff. So that is called presbyopia. So know these three. Astigmatism and strabismus, do not worry about those, because usually they don't ask about these. They like to ask about these three: myopia, hyperopia, and presbyopia. So remember, presbyopia, you have problems, you have vision loss because of your age. After 40s, everyone start having problems with their eyes. Remember, this is the people who have not had problems before. But if you're wearing glasses from day one, when you start going to school, then you have either or hyperopia or myopia. So that's basically how it is. Presbyopia is when you become older, because your eyes start, decaying. That's no longer working as used to. So that's how it is. So these are the major conditions. Now, how do we correct these conditions? Very simple. Glasses. Corrected glasses. That is it. So that's another question. If they ask you a question, a patient has myopia, hyperopia, presbyopia, astigmatismo, strabismus, any of these conditions of the eye, because they are refractive, they can be corrected with glasses. So that's what you see so many people wearing glasses, because they have either or these conditions. But the first three are the ones that are the most common and the ones that are used for tests on your exam, some questions on your exam. So that's basically how it works. Any questions about hyperopia, myopia, or presbyopia? Remember, keep it in mind, because this is what you will be asked. The other ones, do not worry, because that's basically how, it is. Astigmatism. What is astigmatism? When you kind of blink too much. See, if I'm talking to you and I'm blinking all the time, that is called astigmatism. What is strabismus? Strabismus is cross eye. You have one eye looking to the right, one eye looking straight, or one eye looking to the left, the one straight, or the two eyes like kind of looking at each other. If you see someone with one eye on break and the other one focusing on whatever you're doing, then this person have strabismus. Blinking too much, astigmatism. So that's basically what it is. So that's how we identify the patients. And you see these patients everywhere. There is always someone with glasses, but we don't know exactly what it is. The one that we know, and it is physically noticeable, is astigmatism and strabismus, because you see the person that is talking and walking or born and is blinking right there all the time, continuously. So that's strabismus. And the one that has the eyes closed, remember, one eye might be looking straight up, the other one is looking to the right or to the left, or vice versa, or they look in each other all the way, like, they're kissing each other. So that's how we know how the patients are. But remember, astigmatism and strabismus are not questions for exam. presbyopia, myopia, hyperopia, they are. So keep it in mind because it will come out on your exam. Any questions about these common visual defects? And remember, how do we correct any of these 5 conditions, eye conditions or defects? Glasses, glasses. That's how it is. Okay, moving on. Let's talk about this other procedure to check your vision. But this time we're not gonna check your visual accuracy, whether you can see the letters or not. Now is to see if you can see color. Remember, there are color blind people. So if you have a color blind person, then they will not be able to see certain images, certain numbers, certain things. If they have color blind, they might see green as red, as yellow, as blue. So can you imagine a pilot? Can you imagine a cosmetologist or someone who's driving and doesn't see the red light, and the red light, they see it as green? Well, you're gonna get into an accident, right? So colorblind is an issue. And we have a lot of people who has problems with color, identifying color. So that's not good, right? So we are going to talk about this test that is to detect, problems with color. For color blind people, this is called the Ishihara test. Again, this is a question for exam. They're gonna ask you, okay, what is the test that is used for colorblind people, for blind people? Oh, the Ishihara test. Who is Ishihara? Ishihara was a doctor, an ophthalmologist. And this person, most of them are males. So this guy discovered, problems with vision, with colorblind vision. So that's basically what it is. So we're gonna see how that works, because this is a little booklet or some plates, some charts where you're gonna have some background color, and in the middle of this color, you're gonna have numbers and some images, and you have to, read it. They're gonna put it in front of you a certain distance, and they're gonna ask you to read it. They're gonna give you 3 seconds to read these particular numbers or any drawings or any shapes that are within these plates. Once again, for each of these plates, you are going to be given 3 seconds. Of course, the room where you are going to be performing this test gotta be well lit. Very clear, because otherwise, if it's not live, there is no good lighting, then you're not gonna be able to see them, even though if you're not colorblind. So in like any other procedure, you're gonna wash your hands, you're gonna assemble your equipment. Of course, you're gonna greet the patient, you're gonna tell the patient, you're gonna explain the patient the procedure. You're gonna tell them how the procedure is gonna be done. You're gonna tell them that you're gonna show them some plates with some color background, and it's something inside that particular color background. It might be numbers, it might be images, it might be some drawings. So they need to understand what they're going to be doing. So that's basically what it is. There are many number of plates. Some of the tests have 14 plates. Some of them have 18 plates. Some of them have 20 plates. Some of them have 24. Some of them have 36. There are many, many, many differences in which one you're gonna. So in your office, you're probably gonna use the one that has 24 or the one that has 18 plates. So you have to read each one of them, and they're gonna give you 3 seconds to read it. So you're gonna tell me. So they're gonna show you just like the Snellen chart. What letter is this? What is this? So you're gonna read it. But now it is in colors, and you have to be able to identify it. So that's how you are going to record this. Usually you can have 2, maximum 3 plates run. Other than that, you will be considered colorblind. Now you have to be referred to an ophthalmologist for prior, for more specific evaluations. So that's basically what it is. It says right there that this test color blindness is mostly given to airplane pilots. Remember, you need to identify, the lights or the board when they give you signals that you can land or you can depart, take off from the airport, particularly at night when you have to land and you have to make sure that there are no other planes in there. So, or a cosmetologist. Can you imagine a cosmetologist putting the makeup, supposed to put red and they put green, or they're supposed to be green and they put yellow in your face? So that's basically what it is. So once again, if you have the 14 plates, you are allowed to miss 2 of them, and then you will be fine. So that's how you are going to record the results. If you have 18, again, 2. If you have 24, 2. It is only 2 that you can miss. So that's how it works. So this is the Ishihara Color Vision Test plates. So if you look at them, there are 2 circles right here with the first one, like the right one on your side, because, if I'm looking mine, you might be looking on the wrong one. So on your right-hand side, if you look at it, you're gonna have a dark background. On the left-hand side, you're gonna have a yellow background, but inside there are 2 objects, something else, right? So I'm not gonna tell you what it is, but that's what you're gonna tell the patient. You're not gonna tell what is inside, because if you're gonna tell them, then they're gonna know exactly what they're gonna be going through. So that's basically what it is. So you're gonna place each one of them individually. You're gonna play them. So the one with the background yellow and kind of brownish, you see number 74, right? People who has problems, they might see 14, they might see 11. Here on the other side, we're gonna have the background that is kind of gray, like kind of dark, and we have number 42. So if you are not colorblind, you're gonna be able to see these numbers. But if you are colorblind, you're gonna mention something else. Instead of saying 74, you're gonna say 11. Instead of saying 42, you're gonna say, 41. Or just 4, because that's the only one that you can see. So that's how it works. So it's very important for us to understand how this works. Not that you're gonna be doing this much often. I did it because I work in different departments. When I was a medical assistant, that's how I started, remember? But I don't know where you're gonna be working. So if you happen to be exposed or have the opportunity to run this test, it's not difficult at all. You're just gonna place the plates to the patient and you're just gonna pass them every 3 seconds, fold it, pass it, next, next, next. And you're just gonna make sure to see If there are 14 plates and they miss 2, you just remember that they're just gonna miss 2. And that's it. And if they miss 2, it doesn't matter how many plates you have there, you're just gonna count how many they have wrong. And you're not gonna tell them, oh, no, that's wrong. This is what I see. No, because you're not testing you, you're testing your clients. You don't tell the patients that they are, that the letters are wrong. No, that's wrong. Can you go back? No, because that's what they see, whether it's the Snellen chart or whether it's the Ishihara test exam. Remember, the test for color blindness is called the Ishihara. That is 100% question for exam. So don't forget this. So let's check this video quickly. And you're gonna see how the test is done. It's not a long test, it's kind of fast. And you're gonna have an idea how this is going to work. Okay, so here it is. Pay attention to the test. It's very simple.
Ishihara's test for colour vision deficiency. Around 1 in 12 men and 1 in 200 women have an inherited congenital colour vision deficiency. It is useful to screen patients for this using Ishihara's test for colour vision deficiency. The test consists of a series of patterned images or plates. It was designed to assess congenital red-green colour vision deficiencies, such as protanopia, protanomaly, deuteranopia, deuteranomaly. The test was not designed to detect congenital tritanopia or tritanomaly, however these are rare, affecting around 1 in 30. Always keep it closed when not in use, as light exposure may cause colour fading. Avoid touching the plates. Use the provided brush where required. To perform the test, first ensure that the room is adequately lit by diffuse daylight or daylight lamps. The test should be performed at 75 centimetres and perpendicular to the line of sight. Ensure the test is in focus for the patient. Then, ask the patient to read out the number they can see on each plate, if they can see one. Allow 3 seconds for each plate. If the patient is unable to read numbers, you can use the plates towards the back of the book, which show a wiggly line that the patient traces with a brush. Allow up to 10 seconds for each tracing. In cases...
Okay, so she's speaking too fast, right? So what is she trying to tell you is like, if the patient fails to read the numbers that are contained with these images, then they're going to move to the other ones who are shapes. And you're going to ask them to trace them with your finger. So that's basically what it is, because there are some lines that goes, twisting, goes up and down, different shapes. So you're just gonna go over your finger over these lines. So then you've seen them, because you're not gonna be able to see the numbers. So there are different ways of testing the patient. Now, that is not what you're gonna do. What you're gonna do is you're just gonna have the plates where you have numbers, and the patient is gonna read them. That's it. If they see it, they see it. If they don't see it, you just mark all the errors that the patient has. So that's basically.
If the patient is unable to read numbers, you can use the plates towards the back of the book, which show a wiggly line that the patient traces with a brush. Allow up to 10 seconds for each tracing. In cases of suspected acquired colour vision defect, for example in optic neuritis, the test can be performed monocularly with each eye covered in turn. Plate 1 should be visible to all, including those with total colour blindness. Those with total colour blindness will not be able to read any of the plates after this. Plates 2 to 9 are called transformation plates. Normal and anomalous people may read different numbers. For example, Plates 2 and 3, an anomalous person may read 3 and 5. Plates 4 and 5, an anomalous person may read 70 and 35. Plates 6 and 7, an anomalous person may read 2 and 5. Plates 8 and 9, an anomalous person may read 17 and 21. The next set of plates, 10 to 17, are called vanishing plates. Anomalous people usually cannot see any numbers. The next set of plates are called hidden digit plates. Those
So just going over a certain group of numbers because they are in different colors. So for a patient who is, green and red blindness, they have this problem. They're not going to be able to see anything that is green or is red. That's basically what it is. So they are selected in different groups. But that's not what you're going to do. So the only thing that you have to be worried is about showing them the plates and knowing whether they got the right number or not. That is it. That's all you have to do. So what do you see here? This number 5, number 12, number 29. Oh, they say another number. Don't worry. You just know that they say wrong. Move to the next one, to the next one. Remember, we do not correct the patients. We do not tell them, go back again, think again. This is not an exam, when you give options. This is what it is. They're not seeing it and they don't see it. You're not going to frustrate the patient. And we're not going to give them results because these results needs to be given by the medical provider. Remember, that's another thing. You don't give results to the patient because the patient starts questioning you. Why is this? What is that? How's my results? What do you think is the problem? What the doctor is going to do? What they're going to do next? What they're going to order? We're not going to see now. So don't volunteer yourself to give no information. You just do the test, record it wherever you have to record the results. Thank you very much for coming. The doctor is going to evaluate these results and they're going to talk to you, okay? So that's how you're going to do it. So that's basically
with
the
normal colour vision
HHR
cannot
test
see.
works. So I don't like to go over this much because that's the only thing that, I just wanted to show you a little bit how this test works. There was one test that, was kind of good to teach you, but good to show it to you, but it was not complete. It was like lacking a lot of stuff and it was difficult to understand. It was good at the video, but it was difficult to understand. So that's how it's done. So this is the Ishihara test. Remember, you're just going to take those plates. This is like a little booklet, and you're just going to flip the pages, and you're just going to give them 3 seconds for them to read it, and that is it. And then you're going to record 12 out of 14, 10 out of 14, 12, 20 out of 24, whatever the number of plates. You're just going to write down how many rights they have, and that is it. Then the doctor is going to be evaluating the results and is going to making a decision where the patient is going to go next, or where the patient needs to see an ophthalmologist, or if it is an ophthalmologist, whether, what type of, procedures or glasses or anything else they're going to be giving to fix that. So that's basically what it is. So it's not something that, you might encounter, but probably. But most of the time, the Snellen chart, you need to know it. This one is just for questioning. Remember, for exams. Just know that color blindness is used in the test from Ishihara's chart. That's it. Any questions about the Ishihara color blindness test? Okay, let's move to this next one. The Jaeger reading card. Now, this is for near vision. This is close by. This is 14 to 16 inches in front of you. So this is a test that the patient is going to be asked to be reading aloud. So the patient is going to be reading out loud, and it comes in paragraphs. It's not letters. You have to read the entire paragraph. And If the entire paragraph is not read correctly, then the paragraph is not working. So then you go back to the previous paragraph. So look at this sample right here. So you start with the very, very small letters right here. So once again, you tell the patient, which paragraph can you read? Can you read number 1? No. Can you read number 2? No. Can you read number 3? Yeah. Well, then ask them to read it. Or if they can read number 1, number 2, ask them to read it. And if the paragraph that they read, you have to follow it, because you have to have your own paragraph right there. And as the patient is reading, you're looking at the paragraph. It's not that you memorize this. I don't know it. You don't know it. Nobody has to learn it that way. So the patient is reading, and I'm looking at the same paragraph in another card, and then the patient is going to be reading. So that's all you have to do. Ask the patient to read this paragraph, read it loud. Now, they're going to do it exactly like you do the Snellen chart. You're going to read it both eyes. You're going to read it right eye. You're going to cover that one, and then you're going to switch to the left eye. And you're going to record it accordingly. Right eye, OD, left eye, OS, both eyes, OU. This is the body. So what is it that you're going to record? The number right here, number 7, the paragraph. Paragraph of 1, 2, 3, 4, 5. So you ask them to read the smallest that they can read. Because if they are able to read number 3, number 4, you know that number 5, they're going to be able to read it because it's larger. So you're not going to start from the largest one. Sometimes people do that. Okay, can you read number 11? You're not going to spend too much time because it's obvious that they can read it. So you go for the smallest ones first. So that's how I would do it. Remember, you want to save time, and at the same token, you want the patient not to stay there too long, because that's very boring. So that's basically what it is. So let's see if I have this Jaeger right here. There's a little short video that we want to watch for you to have an idea how the test is done. Now, again, this is the most simple way of doing the test. Just asking them to read this. Just hold on. Okay, let's switch. Okay, very simple.
Hey, sir, how are you doing today? My name is Adrienne. I'll be your medical assistant for today. Can you verify your name and date of birth?
Little John, 31157.
Okay, so it looks like the doctor ordered a Jaeger eye chart, a vision test. So what this is going to do is going to test your near visual acuity, okay?
All right.
So all I need you to do is, we're going to hold this clipboard and we're going to measure 14 inches from your eye. You're just going to hold it up straight.
Okay.
And what you're going to do, you're going to use this little paddle to cover up one of your eyes. So we're going to start off with your right eye. Cover up your right eye. Alrighty. So what I want you to do is, without squinting, go ahead and read the smallest box you can read.
That'll be number 9.
Okay, go ahead and read it.
The northern countries of Europe scarcely deserve the expense of labor of conquest of forests and morasses of Germany were.
Okay. Go ahead and uncover your eye. Blink a few times. Cover up your left eye. And read the smallest one you can read without squinting.
Number 9 again.
Okay.
The northern countries of Europe scarcely deserve the expense of labor of conquest in forests and morasses of Germany were.
All right, good job. All right, uncover up your eye. Blink a few times. So now, using both your eyes, you're going to read the smallest print you can read.
Number 5.
Okay, go ahead and read it.
The undertaking became every day more difficult. The events were more doubtful and the possessions more precarious and less beneficial. The experience of Augustine added weight to these salutary reflections and eventually convinced him that by the prudence vigor of.
All right, good job, sir. Can I have this?
Yes.
All right, so I'm going to give these results to the doctor, and he'll be back shortly. Okay.
Thank you.
All right, students. So now the way we're going to document this is, okay, on the patient's chart. OD is right eye, and he read. The print is 9. OS, which means left eye, it'll be J9. And OU, which is both eyes, would be J5. J stands for the Jaeger system chart that he just read, okay? And if your patient was, let's say your patient is wearing glasses, you would just put a note, okay? Either with corrective lenses.
Okay, this was a lot better. Any questions about the Jaeger test for near vision? That's very simple test. So you see, this person started, I didn't even watch the whole video, but this person actually documented as OD, OS, and OU, remember? And once again, if you look at here, is Jaeger and the number of the paragraph. Remember, the paragraph has to be complete. If the paragraph is not complete correctly, then it's not good, that paragraph. You go back to the other paragraph, and that's the one that you're gonna document. So those are very important things. Remember, if the patient has glasses, they have to wear their glasses. If the patient do not wear glasses, well, then you gotta document it without corrected glasses, with corrected glasses, because that's how it works. So that's basically what it is. Now, if you notice during the test, the patient with the right eye read the paragraph number 9. With the right eye, paragraph number 9. But when he was asked to read with both eyes, he read only paragraph number 5. See? So not all the time your eyes can see the same. Your right eye might be different from your left eye or from both eyes. So that is the reason why we are asking the patient to cover one eye while reading with the other one, then switch and then read with both eyes. So that is the purpose, because the eyes do not see in the same way. Okay, when you document, see, these are notes for you to know how you are going to document this particular test on the medical records or wherever this test needs to be recorded. So the documentation, you're gonna document the date that the test was done, the time that the test was performed, what time was done, the name of the visual test performed. What test was done? It was the Snellen test, it was the alphabet, it was the rotating E, or was the object? The Jaeger test, the Ishihara, color blindness. So remember, Snellen test, this is the distance of visual acuity. The Jaeger is the near visual acuity test, the Ishihara color blindness. So remember the results indicating which eye was tested, because you had to place, remember, right eye, left eye, both eyes. Now, if there was some issues that the patient went through during the process of trying to read this, the patient wasn't able to read, the patient was squinting too much, or the patient was leaning forward, depends on the test, then you are going to document it. Or the patient complains about something about the chart, you're gonna document it. Then you're gonna put your initials. Remember, always the initials of the technician. The only one who signs is the medical provider. But because the medical provider is not who did the test, so it's gonna be you, but you're gonna put your signature. I'm sorry, your initials. So that's basically what it is. Remember, you have to record this information immediately after performing the test. Because if you don't do it, then you're gonna have a problem because you're gonna forget. You're gonna have another task to do. And then you're not gonna record, what was, the results from that particular test. One more thing, remember in all these videos, they always said, and if you look at the captions on the videos, you're gonna see that the patient is always asked 2-point identification. Remember, I've been telling you this all this time. Every single time that I'm going to evaluate my patient, I need 2 points identification. What is the 2 points? Patient's name and date of birth. Remember, patient's name is the full name. Name, first name, and last name. It's not 2. Oh, first name, last name, and date of birth, there are 3. No, patient's full name means name and last name, and then date of birth. Always, when you are going to verify patient's identification, you have to ask 2 points identification. Remember, patient's full name, which is last name, first name, and date of birth, because those are questions for exam. Good. Any questions about the test, how to perform them, or whether you understood them or not, and how to document this test on the patient's medical record, whether it's paper medical record or it is in the computer. So that's basically what is needed. Okay, moving on. Ear examination. Now, when we talk about the ear examination, at this time, you're not gonna do anything. This is for the doctors. Anytime that someone has to examine the patient eyes, the patient nose, the patient ears, the patient's body, this is the doctor, not you. You're gonna be doing certain procedures. That's a different issue. So for the purpose of doing an ear examination, you are going to need an otoscope. Remember, an otoscope is this instrument that is used for examining and visualizing the ears. So OTO, auto, means ears. Be careful because when we pronounce them in American English, we said auto. You don't say otoscope. Well, if you're British, probably you can say that. But here in America, most of the time, we use auto. But oro, do not confuse oro with actually O-R-O, because this means mouth. So otoscope and otoscope are not the same. So otoscope, if you pronounce the T, then this is the ears. But sometimes we pronounce the T as an R, so just know what is the patient here for. If the patient is complaining about not being able to hear, that they feel like they have something in their ears, then it's otoscope, but with T. But if it is something in the mouth, then it's otoscope with an R. So be careful because that's the problem with medical terminology and how we pronounce things in English. So that's basically what it is. So what is it that we actually going to examine when we examine the ears? The external canal, anything that you can see on the outside, and the little canal where you place the Q-tips or your finger to try to remove something. That is the external ear canal. We will go over anatomy and physiology, has this part of, the anatomy and physiology. During anatomy and physiology, we're gonna cover the ear and its structures, its parts. But the external, as the word implies, external ear canal is the little like tunnel that, allows the sounds from the inside to go in and then meet the tympanic membrane. Because the tympanic membrane is a membrane that separates the external canal. This is the external canal. Here is the tympanic membrane. Here is the middle ear. And here is the inner ear. So we're going to evaluate this part right here and this tympanic membrane. Meaning we're going to see the tympanic membrane and make sure that this tympanic membrane is patent. So it is in good condition. Then we're going to be able to see something behind the tympanic membrane, which is the middle ear and some little bones there. So once again, this is job of the doctor, but when we have anatomy and physiology, we're going to learn the parts of the ear. So the medical doctor is going to use an otoscope to place it right there inside the ear canal, and then through that lens, they're going to look inside. Remember that these otoscopes are electrical charge, battery operated, so we got to make sure that we have this charge if they need to charge, or that they are plugged to the electrical current if they are electrical. So that's basically what it is. Now, the part that enters the canal from the otoscope is not the otoscope itself, it's the specula, little cone-like cover that is placed to the otoscope. So this is the only part that enters there from the otoscope, and is disposable because remember, these are body fluids right here. So we don't want to contaminate the instrument. So here is the instrument that the medical doctor is using. Well, the part that goes inside goes this way. And here we put the probe, the little specula, which is the one that enters the ear canal. And then the medical doctor, of course, this is not how it's done. The medical doctor has to put the eye right here. From here, you don't see anything. So that's how it is, but it's getting ready. That's what it is. It's placing the otoscope now. This medical doctor or provider is going to get very close right here to put an eye right in the lens to see what's going on inside. So that's how it works. This is an otoscope for the evaluation of the ears. Remember, it's just to see. The otoscope only is going to be useful to see the external canal, the tympanic membrane, and part of the middle ear, because the tympanic membrane is kind of transparent when it's normal. So you can see, like, these transparent curtains, you can see behind the curtain the big shape of something over there. Well, these little three bones that are behind there. So that's basically what it is. There are three ossicles. We're not going to talk about that, but this is how it works. So this is what the otoscope is used for. Remember that the questions are straightforward with these instruments. What's an otoscope? Oh, this is an instrument that is used to check, to examine, to visually evaluate the ear. What is an ophthalmoscope? Oh, that's for the eye. So this is an instrument. anytime that you hear or see the word scope at the end, means instrument. Then whatever is next to them is going to describe, the type of instrument that you're going to be using. So that's basically what it is. Okay, conclusion. So we conclude with this chapter. So once again, what I've been telling you all this time, you have to be very careful when you're treating the patients. Remember, you have to treat them respectfully, professionally, with dignity. Remember, you don't want to embarrass them because they might have physical problems, deformities, physical conditions, mental conditions. So we have to respect each person. Remember, we have to help them out. We have to do our best to make the stay during that particular visit as pleasant as possible, particularly when we are assisting them to do procedures, because they're going to be very apprehensive. They are not going to be apprehensive just for the position that we're going to put the patients in, but for the results. Remember, when you go to the medical doctor and they order a blood test because you were having some problems, you're not worried about the needle. You're not worried about the tubes. You don't worry about getting a bruise and a hematoma. You worry about the results of that test. So their minds are going to be everywhere. So be careful. They're going to be very sensitive. And for that reason, they can snap very easily when you interact with them, when you say something that probably they don't like it or they perceive as offensive. So be careful. If we don't know the answer of something, don't give no answers. Particularly, don't tell them anything about results. The doctor is going to talk to you. The doctor is going to explain you that. The doctor, throw it to the doctor. Even though if you know the results, do not tell the patient. Don't tell the patient the results, please. You're going to get in so much trouble. I'm telling you, even though if the results are negative, don't tell them. Because sometimes there are false negative results. And when the doctor talks to the patient, the doctor is going to tell the patient otherwise. Your results are negative according, but I'm going to order other tests because I think that I need to do further evaluation. Then the patient is going to tell you, oh, but the nurse, the medical assistant told me that everything was fine. Now you're putting me in trouble. How am I going to explain the patient who is telling the truth? Now the patient don't trust the medical personnel because you open your big mouth to give the patient advice, tell results, or tell something that you weren't sure about. Remember, don't get in trouble. Less is more. The less you talk, the better for you, the better for everybody. Don't give no results, even though you have them in your hands. Doctor is going to discuss that with you, okay? Thank you. There is anything else I can help you with? No. Okay. So please have a seat. The doctor will see you. Or please come to the office if it is over the phone. You have to give the news, something like that. The patient had to come. Oh, what was my results? Please, you need to come to the office. The doctor is going to discuss that with you in person. Oh, can you give me a little advance? Is it bad? Is it good? Because we always tend to, to get to know beforehand. We are very curious people. Don't volunteer to say anything. The doctor is going to discuss with you. So see you tomorrow at 10 or see you at 4 p.m. today. That's it. Dismiss them, but very courteously. This is how I do. I'm telling you, I'm so used to that. No, because I don't want to get in trouble. I never got in trouble with anything because I never opened my mouth to say something that I shouldn't say. Even though if I knew it, I didn't say it. people get kind of angry or patients or something like that. I don't care. Listen, you're not paying my bills. If I open my mouth and get fired, you're not gonna pay my bills. So thank you very much. Just wait for the doctor to tell you the results because I will not give you that answer. Believe me, I'm telling you all this based on experience because we tend to try to be nice. Oh, if I tell the patient, no, it's okay, it's fine. You know, your results are negative. Don't worry. No, because probably they weren't negative at all. That's what you see, but you know, it is not always what you see because you're not a medical doctor. There are something else because the patient still have symptoms. The patient were there for a reason. And because the labs are negative, does not imply, oh, you don't have anything, but I still have the symptoms. So I do have something. They might have to do something else. Because if I tell the patient, no, you're fine. No, you're not fine. Because I feel something. That's the reason why I came to see the doctor. Now you're going to put yourself in trouble because the doctor is going to hear that from the patient because you told them that everything was fine. So be careful with all that. That's my personal advice. Okay. Any questions about anything that we have covered up to now from this module? Anything at all? You guys kind of too quiet. You should be bombarding me with all these questions, right? Oh, just kidding. Okay, so probably was very clear. Probably, you know, just don't be shy. Don't care about any one of your classmates. If you have a question, don't feel embarrassed. Because maybe not only you are confused about something, maybe some other ones are confused that just want to talk. So always stand out for yourself. I always tell you that because you are alone. When you start working, nobody's going to be with you but you. Nobody's going to be helping you. Nobody's going to be solving your problems. Nobody's going to be paying your bills. It's going to be up to you. Okay. All right, so then we are done with this chapter. We are done with this week. I'm going to be seeing you on Monday, and we continue with whatever or whichever other chapters are left. Okay? Enjoy your weekend. Stay safe. Stay warm. God bless you, everyone, and see you next week then. Take care.
Thank you. Have a good
Thank
night.
you. Good night.
Likewise.
Thank
Take
you.
care.
See you
Thank
next
you.
week.
Bye
Bye.
now. See you next week. Take care. Enjoy the weekend. Get some rest.
Good night.
Good night. Take care.